A very good morning and a warm welcome to all of you. I hereby invite you to the first scientific session of the International Pharmacology Conference, that is 55th Annual National Conference of Indian Pharmacological Society, IPSCON 2025. It is my most proud privilege to invite our chairperson for the session, Professor Bhupinder Singh Bhoop, our very own Bhoop sir. So please grace the dais. Professor Bhupinder Singh Bhoop is a highly renowned and respected pharmaceutical scientist at University Institute of Pharmaceutical Sciences, Punjab University, Chandigarh. His research specialization lies in quality by design enabled nanostructured drug delivery system, advanced pharmacokinetics and biowaivers are his specialty. Over his distinguished career, Professor Bhoop has published over 430 research articles. He has authored and edited almost 16 books and secured 8 patents. He has successfully transferred 3 of his nano-based formulation to the pharmaceutical industry. At Punjab University, he has held several leadership roles. He was chairperson UIPS from 2014 to 2017, Dean of Faculty of Pharmaceutical Sciences, Dean Alumni Relations, and a member of University Senate and Syndicate and the coordinator of UGC Center for Advanced Studies in Pharmaceutical Sciences. He is also the founder and coordinator of National UGC Center for Excellence of Nanobiomedical Applications. His excellence has been recognized with numerous awards. He received Acharya P.C. Ray Memorial Gold Medal from Indian Pharmaceutical Association in 2024. In 2024, the Punjab Academy of Sciences conferred upon him its Lifetime Achievement Award, citing his pioneering contribution in QBT-based nanomedicine research. Professor Bhoop is widely regarded for his role in training and mentoring. He has guided more than 110 PhD students, over 11 postdoctoral researchers, and thousands of industrial scientists through workshops. His global presence is significant. He has delivered over 380 invited talks and workshops in India and abroad. He is also deeply engaged in academic governance and professional bodies, serving as an expert for UGC, DST SERB, AICTE, and PCI. With this, we welcome you, sir, and it's a pleasure to have you with us. Thank you so much for sparing your time and joining us. Next, I would like to invite our co-chair for the session, Professor Abhay T. Sangamwar. Sir, please grace the dais. Professor Sangamwar is a PhD and professor in the Department of Pharmaceutics, Naipur, Mohali. He earned his PhD from Swami Ramanand Tirth, Marathwada University, and he has devoted his research to novel drug delivery systems, including polymeric micelles, lipid-based carriers, solid-state formulations like amorphous dispersions and co-crystals. Professor Sangamwar has guided numerous graduates and PhD students, taught advanced pharmaceutical courses, and published widely on formulation strategies to improve solubility, stability, and bioavailability of poorly soluble drugs. So with this, I invite you, sir, and it's my huge pleasure to please request you to introduce our first speaker of the day.
Good morning. I hope you had decent breakfast. So the response should be loud and stiff. Good morning. That's the way it should be. So we are geared up for the day. So the first speaker is Subhasri Rao Chaudhary. She's a scientist. Our work focuses on designing siRNA or drug-loaded nanoparticles to modulate epigenetic regulators in cancer, especially leukemia and solid tumors. And she's also exploring nano-based interventions for
Good morning, everyone. First of all, I would like to thank Professor Rupinder P for such a nice introduction, and I would like to thank the organizer for giving me the opportunity to present my work here. I basically work in epigenetic regulations of cancer and neurodegenerative disorders, nanotherapeutic interventions, but like here I will restrict my talk mostly on leukemia. So I basically work, like my lab is basically interested in working with cancers including glioblastoma, neuroblastoma and leukemia, and also neurodegenerative disorders, like among them we work mostly in Parkinson's disease. But today I will mostly focus on acute myeloid leukemia. So before going in details to acute myeloid leukemia, let me give you a very brief of what is hematopoiesis. So hematopoiesis is the formation of blood cellular components, So hematopoiesis is the formation of blood cellular components from hematopoietic stem cells. So what happens, like the bone marrow forms the blood stem cells either from myeloid origin or myeloid stem cells or like lymphoid stem cells, which undergoes like proliferation, differentiation and maturation to give rise to either like blood cells of RBCs, platelets and myelocytes, whereas the lymphocytes, the lymphoid progenitor stem cells gives rise to the T lymphocyte, B lymphocyte under proliferation, differentiation and maturation. But when there is an impairment of this proliferation, differentiation and maturations, it gives rise to a pathophysiological conditions named as leukemia. So if it is from the myeloid origin, it gives rise to myeloid leukemia, which can be further classified into acute and chronic, whereas the lymphoid origin gives rise to lymphoid leukemia. So, and this AML, as I told, it is a heterogeneous clonal disorders of myeloid hematopoietic progenitor cells, which is highly prevalent in India. Survival rate is also very poor, like 25%, and like 5-year survival rate. And 15% of all hematological malignancies is due to this acute myeloid leukemia. So, both the cases, our main goal is to look for epigenetic regulations. So, we are basically interested in a master epigenetic regulator, that is polycomb group of proteins. So, if you consider this as a chromatin, and the DNA is wrapped around this chromatin with functional units like the nucleosomes, which are comprising of core histones and with the protruding histone tails. So basically, the polycomb repressive complex 2 member causes the trimethylation of histone, and then the polycomb repressive complex 1 member causes the ubiquitination of those trimethylated histone. Therefore, like compacting the chromatin or closed chromatin-like structure, so the gene cannot be transcribed. So which genes can be transcribed? So tumor suppressor genes. So basically, those genes which are responsible for inhibiting cancer cells, progressions or induction of apoptosis, induction of differentiations, those transcription of those genes are being arrested. So basically polycomb group of protein, we can tell in other hand, aggravates the cancer. So we are basically interested in that in both the cases, like in leukemia or in PD. So since last 5 years, like we have from our lab had established that there is a DNA binding transcription factor, CME, which is highly overexpressed in case of acute myeloid leukemia. And we were the first to prove that these CME is binding to this polycomb repressive complex like BMI1 and EZH2, and thereby they are responsible for the onset, maintenance and pathogenesis of AML. So we have targeted those pathway through either small molecule inhibitors or the siRNA in a nano-encapsulated form to inhibit those CME-mediated AML reiteration. So which we have published in Applied Material today, AMI, Molecular Pharmaceutics and JMCB. So what new thing we are doing? So we, in the literature, if you see, there we can find that the AML is due to the fusion oncoprotein rearranged AML. So what is that all about? So if you look for, there are two proteins like AML1 and ETO1. They can independently cause the AML. But when they are fused in T821, then they form AML into a fusion protein that is responsible for 25% or 20% of the AML. So basically they can aggravate more pronouncedly responsible for the pathogenesis of AML. Similarly, if you look for MLL and AF9, those two can independently cause the AML. But when their chromosomal translocation or reciprocal translocations happen at T911, they form a fusion oncoprotein named as MLL-AF9, and these can cause up to 25 to 30% of AML. So in our lab, we are mostly working now with a fusion oncoprotein rearranged AML. So AML-ETO, AML-AF9, FLT3-ITD, PML-RARA. But here I have constricted in two this fusion protein, like AML-ETO and MLL-AF9. So this is one new thing we're doing, and another thing is we are targeting the our cargo through nanoformulation mediated delivery through targeting through functionalization of the nanoparticle. So basically in AML cells, if you look for, there are CD123, CD33 are highly overexpressed. So we are functionalizing our nanoparticle through aptamer that specifically bind to those surface protein like CD123, CD33 through different aptamer like ZW25 for CD123, S30 for CD33, and they can easily deliver the cargo specifically to AML cells. And not only that, we are also targeted with the antibody conjugated nanotherapy for delivering our nanomaterial. And also we have target, as I told you, this is basically the disease originating from the bone marrow. Like the hematopoietic failure mostly starts in the bone marrow due to the abnormal accumulation of the progenitor cells. So we are targeting the bone marrow with alendronic acid, ibandronic acid to deliver our nanomaterial. So in our first study, we have done CD33 targeted aptamer conjugated HSNP for EZH1 inhibition, and it's checking its therapeutic efficacy. So we have synthesized human serum albumin nanoparticle, and we have functionalized with S30 aptamer that can target the CD33, which is highly overexpressed in AML. And here we have encapsulated EZH1 siRNA. So what is this EZH1 siRNA? This is a polycomb repressive complex 2 member, and it causes also highly overexpressed in case of AML. So we were the first to prove, we have to check this AML, in AML cells in fusion oncoprotein rearranged AML, that is AML-ETO model. So how we have done it? So basically in the AML cells, we have synthesized the retrovirus in HEC293 transfecting this AML ETO plasmid with a packaging plasmid like VSVG, GAPPOL, and then we have the collected the viral soup and concentrated it, and then we have infected the U937 cells to generate this AML ETO 9A infected these cells, and then we have checked the particle size. So we found it is like around 100 to 150 nanometer range, and we have checked the stability through RNase assay and RNase protection assay and serum digestion studies. We were found it to be stable, and then we checked the transfection efficiency. So transfection efficiency here we have compared with the market available siRNA with our nanocargo mediated delivery of the siRNA, and we have found when we have used the transfection reagent and transfection medium for the market available siRNA compared to our nanocarrier without any transfection reagent or medium, we found this increasing the transfection efficiency to 2 to 2.5 fold more, and it is internalizing in the cell, and also it is inhibiting the AML ETO induced U937 cell viability in the inducing apoptosis of the AML ETO in U937 cell lines. Then we checked the therapeutic efficacy in a nude mice xenograft model. So here also we have infected, induced the nude mice with AML ETO infected cells, and after the treatment we have checked the leukemic stem cells marker like the CD34, we have checked the CK positive expressions, and we found that it is downregulating the leukemic stem cell marker with concomitant increase in GR1 CD11B, the myeloid monocytic differentiation marker. So not only in nude mice xenograft models, so we have also checked it in patient-derived xenograft models. So how we have done it? So we have basically from the PGI-AMR, from the AML patients, we have collected the blood, and from the blood we have collected the PBMCs, and then from the PBMCs in our lab we have sorted the CD34 positive, CD38 negative leukemic stem cells through MAX, and then we have infected the similar we have done with the AML ETO retrovirus. We have synthesized in our lab, and we have infected those cells, CD34 positive, CD38 negative cells, and then we have induced it in the non-skid mice, followed by our nanotherapy, and we have found here also they have increased the survival period of the mice, and they decreased the splenomegaly, and also we found the inhibition of the leukemic stem cell markers with increase in myeloid monocytic differentiation markers. So then we were curious to know what is the mechanism. So we've also checked the biodistribution, and we found they have been cleared from the reticuloendothelial system, and then we would like to check the mechanism of action, and we found our nanotherapy completely downregulated the CME expression H3K27ME3, that hallmark of epigenetic gene silencing, that is also they've been downregulating EZH1 expression, and also they have increased the caspase-3 expressions. And then after that we have done the IP and the chip studies, from where we have found CME is binding directly to we are the first to show that CME is binding directly to the EZH1 promoter region, and our nanocarrier mediated delivery abrogates this interaction mediated AML inhibition. So this work we have published in Nano Today. So my next study, we have done it in we have targeted here different targeting strategy like CD123 with ZW25 aptamer. Here also we have taken this human serum albumin nanoparticle, and here we have encapsulated EZH2 siRNA, and we have checked the size also. It is around 100 nanometer, and it was highly stable through RNAs and protection assay and serum stability. And we have found that it also improves the transfection efficiency in case of MLL-F9 rearranged AML, and it also inhibited the MLL-F9 induced retrovirus. We have also synthesized MLL-F9 retrovirus in our lab, and then we have infected the U97 cells and other ML cells also, and we found it is inhibiting the cell viability and inducing apoptosis. And then we checked the efficacy in case of nude mice xenograft model, and we found here also like the GFP expression, which was a fusion protein in the MLL-F9, was downregulated with leukemic stem cell marker c-KIT was also downregulated, and we have checked the GR1 CD11B, which is myeloid monocytic differentiation marker, were found to be upregulated, and it also reduces splenomegaly. So then similarly, we have taken like PBMCs, we have isolated from the patient blood from the PGIMR, and then we have infected, sorted the CD34 positive, CD38 negative stem cells, and then we have infected with AML and AF9 in our lab, and then we checked, we induced this in the not-skip mice followed by a delivery, nanoparticle delivery, and we found here also they are increasing the cell survival and increasing the survival of the animal, and decrease the c-KIT positive LSCs with myeloid monocytic differentiation marker were increased. Then we tried to find out the mechanism, and we have shown like here also in case of this MLL AF9 induced fusion of a protein rearranged AML, CMIB is binding to the EZH2 promoter, which has been inhibited by our nanoparticles. So we have found with the Western blot, we have checked the different molecular marker expressions. Distribution also, it was cleared from the reticular endothelial system, and this work we have recently published in Advanced Healthcare Material. So my next study, so as I told, like we have taken different targeting strategy. So these two are mostly aptamer first. So next we have targeted the bone marrow with ibendronic acid, that is a bisphosphonate, that we have functionalized our nanocarrier, that is here we have taken the vitamin D nanoemulsions and we have functionalized with ibendronic acid, and here we have encapsulated c-MIB siRNA. We found they are targeting the nanoparticle size was around 100 nanometer range, and in the ex vivo bone slices through FSM we found they are like localizing in the bone, and also we have checked in the in vivo studies like they are mostly like localized in the hind limbs, forelimbs, vertebrae, and when we have like bone marrows we have taken from the femur bones, we have found they are like they are localized there also, but when they in presence of the antagonists like the hydroxyapatite or PEG-2000, when we have coated the particle with PEG-2000 or PI or hydroxyapatite, then this bone targeting was inhibited. So they are specifically targeting the bone marrows, and so then we have checked the cellular internalization, and we found they are internalizing in the cells and also increase the MLL-F9 cytotoxicity, and they increase annexin positive cells and increase the apoptosis also. So then we checked in similarly like in the nude mice xenograft model, and here also we found like they are reducing the splenomegaly and decrease c-KIT positive leukemic stem cells population and increasing the myeloid monocytic differentiation marker. We have checked it in patient-derived xenograft models, and we found that it is also increasing the survival period with the decreased c-KIT populations. So then we were curious to know the mechanism. So here we have found that our nanoparticle mediated delivery inhibited the c-MIB expression, survivin expression. We found, so what we have done, we have found here like CM2 cheap acid, we found like c-MIB is binding to a particular promoter region of survivin and then responsible for this AML progression. But our nanocarrier is inhibiting that promoter binding. Not only the binding study, we have also checked the promoter activity. So for that, what we have done, we have taken that particular promoter region where the c-MIB is binding to survivin, and then we have inserted this in the luciferase vector, like PGL3 IRS luciferase vector, and we have checked the promoter as through the promoter functional assay. We have checked the activity promoter activity. So we found his down-regulating that also. So this work has been published in ACS, Applied Material Interfaces, and similarly we have targeted with alendronic acid also through functionalizing HSN nanoparticle for the inhibition of AML ETO9A. Here we have encapsulated the small molecule inhibitor of ring 1B and the polycomb repressive complex member. Sorry for the time, I'm not going in details. So I found the one, yeah, sure, sir. So we have also established this thing, and this is under review. And lastly, we have, as I told, the targeting efficiency, we have also taken in account like the antibody conjugation. So we have functionalized here the chitosan nanoparticle with, we have antibody with CD56, we have antibody functionalized, so that can target like CD56 positive NK cells. So here basically the concept was like the adaptive transfer has lots of problems. So and the AML cells have many like difficulties, like anti-tumor immunity they cannot do because of these defective NK cells, because the NKG2D receptors were defective. So we have tried to compare our strategy like with the adaptive transfer, and also we wanted to in vivo genetic engineer these NK cells through the delivery of this CD56 functionalized chitosan nanoparticle, which is loading with EZH2 shRNA plasmid. So here also we have found like they are showing excellent efficacy compared to the adaptive transfer, the downregulation of EZH2 with the increase in CD56 NK cells, CD38 and granzyme productions, and also we found the another EZH2 NPM1 interaction was inhibited. So this work we have published in nanoscale. So also we have done it in, we are mostly working also in like PD. Recently we have published in this PD therapies. And lastly, I would like to thank our Director INST, Professor Surajit Karmakar, INST Mohali, Dr. Pankaj Malhotra, the clinician of PGIMR, and my excellently hard-working student, Dr. Avinash, Dr. Babita, and Dr. Nadine. So and lastly, I would like to acknowledge like the funding support from the DST, DBT, CSIR, and ICMR. Thank you for your kind attention.
Excellent kind of work. So any questions, please? Please feel free to ask any questions. So I must compliment on behalf of the organizers and on behalf of the organizers for outstanding work you have done. You have tried to sum up, saga into saga, and so much of good work published in Nano Today and Nanoscale and HSN and so on. I must compliment and I must inquire. You have worked on patient-derived xenograft.
Yes, sir.
Human patient-derived.
Yes, sir. Yes, sir.
To mice, probably new mice,
yes, sir.
and used it for your studies.
Yes, sir.
And this is probably the culmination of what should be done in the preclinical studies for not only nanostructure, any kind of system. So, did you develop it at in INSP?
Yes, sir. Yes, only in INSP, sir.
Okay.
We don't have the animal facility till last year, so from then, like we have like, and until that period, Iser Mohali helped us a lot to do all the studies in the NIPER also, for the neurodegeneration studies we have done with Professor Sharma. So like he also helped us a lot. And then after our own animal house has been built up, so we are doing it in our own.
But you are working on acute myeloid leukemia.
Yes, sir.
So it's prevalent across the world.
Yes, sir. Across the
So,
world.
so which organ were you given?
In the bone marrow.
Bone marrow. Yeah. What do you think about microfluidics based organ on
Yes, no, we have. I have not done there, but yeah, we can definitely check in that also. That's also another very emerging area.
So you must think,
yes,
since we are working in a very progressive institute, with high quality of infrastructure, so you must think of developing, this kind of technology in this part of the country, microfluidics based, organ on a chip, lab on a chip, and probably you will be doing. only a couple of years ago, this is 25, I think 22, FDA has allowed microfluidics-based predictions using emulate software to be used as a surrogate to preclinical studies in animals. This is fantastic from industry point of view and from research point of view. If you develop such kind of chips, not only you can patent them, you can use them, you can transfer this technology to so many industries who can market that chip, and it will be a service to the society as well. Augmenting the prediction of the models, correct prediction of the models in a so over to you, sir.
Thank
you are also nanotechnology doctor. We must compliment once again.
Thank you so much, Dr. Chaudhary, for your elaborate presentation. I would now request our chairperson to please felicitate Dr. Chaudhary. Thank you, sir. Thank you so much. So I now request our chairperson for the session to please introduce our second speaker of the day.
Good morning. So I'm happy to introduce my own colleague, Professor Anupama Mittal, who is a professor in the Department of Pharmaceutics, Microbiology. She leads pioneering research in nanotechnology-based drug delivery, including lipid and polymeric nanoparticles, polymeric micelles, polymer drug conjugates, and stem cell derived exosomes with applications in diabetes, cancer, protein peptide therapeutics, and regenerative medicine. Dr. Mittal's work also spans delivery of mRNA and CRISPR-Cas systems, and she holds multiple patents in advanced drug delivery. Please.
A very good morning to everyone present over here, and thank you Professor Bhoop, Professor Sangamwar for that generous introduction. So without wasting any time, I would like to go ahead with my presentation. Before I start with the actual work that I would like to present today, I would like to give a brief overview of the work that we are doing in my lab. We are primarily working in the disorders like diabetes and cancer, and recently we have ventured into antimicrobial resistance through the agency of small molecule drugs, microRNA and peptides. And as we know that these molecules are very difficult to deliver, we are synthesizing different types of nanocarriers, including lipids as well as polymeric carriers, conjugates, micelles, liposomes, etc. And we are also working on synthetic nanovesicles, that is exosomes. And our aim is to go ahead for technologies that could be translated from bench to bedside. We are synthesizing different types of multifunctional carriers that could be formulated into nano formulations. We carry out formulation development in vitro and in vivo studies. And these pictures which you see here, this shows one of the products of a drug, a small molecule drug with a weight of 280 daltons that has been tech transferred. So this molecule was lisofilin, which is otherwise delivered by a 10 hours infusion in clinical trials, and we have been able to convert it into orally viable tablets, which you see over here. And this work has also been tech transferred to Anya Capital, and now we are taking it ahead for GLP-based toxicological studies and scale-up of the formulation. But today I am going to talk about delivery of a protein that is interleukin-1 receptor antagonist. So as we all know that diabetes has been increasing tremendously, and in our own region there has been an increase of 73% in the cases of diabetes. And if we look into the pathogenesis of diabetes without going into details, it is considered as one of the chronic inflammatory diseases with latest technologies like transplantation of pancreas, islets and stem cells for treatment of type 1 diabetes. However, none of these therapies have been able to give a complete relief from insulin therapy. Here in FPC, it's the increased level of glucose and free fatty acids in the blood that results in glucolipotoxicity and inflammation of the adipose tissue, which increases the inflammatory cytokines like IL-6 and TNF-alpha in the body. Presence of free fatty acid further increases this inflammatory pathway and increases the level of inflammatory cytokine IL-1 beta, and this is further supported by the increased levels of glucose in the blood. This pathway acts through binding on IL-1R receptor, which acts as an autocatalysis for further aggravation of this pathway. And all this together increases the level of inflammatory cytokines, chemokines, and inflammation of islets and dysfunctioning of beta cells, resulting in decrease in the level of insulin secretion. This, along with increase in IL-6 and TNF-alpha, results in apoptosis of the beta cells, ultimately resulting in type 1 diabetes mellitus. Herein, one of the key players could be blocking the action of IL-1 receptor so that IL-1 beta cannot bind onto this receptor, and this could be carried out by IL-1RA. IL-1RA is present in our body endogenously. However, it has been well reported that in patients of type 1 diabetes, the level of IL-1RA is substantially compromised. And herein, our aim was to restore the level of IL-1RA in the body so that it can inhibit the action of IL-1 beta, and thus it can provide relief to type 1 diabetic patients. However, being a protein molecule, it has a molecular weight of 17,000 Daltons. It's a macromolecule, and hence it is very difficult to deliver. And as for any other protein, it has got a very short half-life of around 4 hours. It needs a high frequency of administration and a continuous frequency also to maintain its therapeutic levels in the blood. There are complex formulation procedures which are reported for IL-1RA, one of them being pegylation. Pegylation is a very well reported procedure for increasing half-life of these molecules, but it has also been found that pegylated IL-1RA shows only 9% of the activity what is shown by native IL-1RA, clearly showing that this therapy is not the solution to the delivery of IL-1RA. So this is a research strategy that we came up with. We synthesized two different types of carriers. One was lipid-based carrier and other was a cationic carrier in the lab. So the rationale for synthesizing a cationic carrier was that IL-1RA, being a protein, has isoelectric point, and as we all know, at isoelectric point the proteins are having a net zero charge. But if we can interplay with the pH, we can bring the proteins to a negative charge, and using this cationic carrier we can complex the protein. So this was the hypothesis, and with this we formulated IL-1RA without using any chemical reaction, without using any covalent conjugation. In addition to that, we synthesized another lipopolymer that is cholesterol based, and the importance of having cholesterol here was cholesterol helps in stabilization of the membrane of the carrier, and it also helps in enhanced cell internalization. We use these two carriers, their different ratios were optimized to obtain an optimal delivery of the protein molecule. So, as I told, these carriers were synthesized into the lab. I will not go into the details of the chemistry of these polymers, a multi-step synthesis procedure was followed to synthesize the cationic polymer. This has been reported by the lab for the first time, and this has been patented by us. We also carried out NMR-based studies, HRMS and GPC for characterization of the polymer, and the polymer was found to be of a molecular weight around 10,000 Daltons. We further synthesized the lipid-based polymer, again by a multi-step procedure, which was characterized through NMR-based studies. Now, before going to a bulky molecule like IL-1RA, we thought of using simpler peptides and microRNAs to see if the strategy works of complexing a positively charged polymer with negatively charged biological molecules. To meet this end, the first molecule that we selected was C-peptide. It has a lesser molecular weight, that is 3,000 Daltons, and like IL-1RA, it also has an isoelectric point which is in the range of 3 to 3.77. And again, it is very difficult to deliver. And the second molecule that we selected to test the polymeric delivery system was microRNA 29B, which has a role to prevent renal fibrosis. And this is a 22 base pair microRNA, which is again very challenging to deliver because of its quick degradation in the body. So first I'll show the delivery of C-peptide using this system. So we synthesized the carriers and we made the formulation. We optimized different ratios of the cationic and the cholesterol-based polymer, wherein we zeroed upon 2:1 ratio of the two, wherein 2 times was a cationic polymer and 1 time was a cholesterol-based polymer. And when C-peptide was complexed at a particular pH with this system, we found that it gave a size of 178 nanometer and a complexation efficiency of 70. Also noteworthy here is that while the zeta potential was positive because we were taking a cationic carrier, when C-peptide, which was negatively charged, it was complexed into it, the zeta potential was brought down to 6, which is seen here also in this graph. Further ahead, to confirm the complexation of C-peptide, we perform native page, and what we see here is this is free peptide which migrates freely on the native page. But these are the different complexes at different ratios, and herein we found that when with image J we analyzed the intensity of the complex C-peptide, which was not able to migrate but it was retarded in the well, it was 57% of the C-peptide compared to the theoretical amount of C-peptide that was added, and whatever free amount of C-peptide was there, which was not complex, it just migrated on the page. Further, to confirm the C-peptide loading, we went ahead and the C-peptide was dissociated in the presence of a highly acidic pH, and this C-peptide, which you see is retarded here, only this C-peptide was taken. Considering this as 100%, we found that 97% of the C-peptide was eluted out. It could be dissociated, and it is very important that we are able to complex the peptide, and equally important is we are able to release the peptide from the system so that it can show its therapeutic action. Further ahead, because we were using cationic carriers which are known to be cytotoxic, we checked their safer concentrations, at what concentration we could work in different cell lines. We also checked that whether these could be internalized into the cells or not by synthesizing FITC labeled C-peptide, and herein we see that when we are not using cholesterol, when only cationic polymer was used, hardly any internalization into the cells was seen, but at other formulations wherein cholesterol was also used, the internalization was quite high, which was further confirmed by flow cytometry also, and was found around 70% in all the cases. Further in the cells, we induced metabolic and oxidative stress by giving conditions of a very high glucose and in the presence of H2O2, wherein a significant decrease in cell viability was observed. However, in the presence of C-peptide nanocomplexes, there was a substantial increase in the cell viability under these conditions. Not only that, a very potent marker of inflammation, that is NO, was found to be substantially reduced when the cells were incubated with C-peptide nanocomplexes, and there was a substantial increase in the level of glutathione, that is GSH, which is a known antioxidant of the body. So that was about C-peptide, and then we synthesized the microRNA based formulation. In microRNA based formulation also, we took a 2:1 ratio of the two polymers and we found the size to be around 132 nanometer and the complex percentage of microRNA was around 48%. In case of microRNA, we performed gel retardation assay wherein the free microRNA gets eluted out. However, at different ratios of polymer to microRNA, we see that at one particular ratio, that is 20, complete microRNA was retained in the well and nothing could be eluted out. Later on, microRNA was again dissociated with the system in the presence of heparin, wherein microRNA got eluted out, which shows that microRNA after complexation is also intact. We further checked its internalization or transfection as compared to a marketed vehicle, that is lipofectamine, and we see there was a marked increase in the uptake or the transfection of microRNA. In terms of flow cytometry, 22% transfection was observed with the lab synthesized transfection agent as compared to the marketed one, lipofectamine, which is only 5%. This work has also been patented and published in Biomaterial Advances. And with this, we wanted to take this ahead as a platform technology for delivery of peptides and microRNA, and next we delivered IL-1RA based nanocomplexes. Again, these were synthesized and we found that after complexation of IL-1RA into nanocomplexes, we could not see any band of free IL-1RA which was seen in case of standard IL-1RA. Its molecular weight is 17,000 kilodaltons, which could be verified over here. This is the picture of the complex particle in TEM. Just to confirm the integrity of IL-1RA, we performed circular dichroism and we see that for the free IL-1RA as well as after complexation, the structure was not disturbed as verified by circular dichroism. We performed the cell internalization assays, and sir, kindly allow 1 or 2 more minutes. We performed the cell internalization assays, and since the concept was that IL-1RA should block the action of IL-1 beta, initially there was a very high uptake of IL-1RA nanocomplexes, but when we incubated it in the presence of IL-1 beta, the uptake was completely blocked, giving us a confirmation that IL-1RA nanocomplexes were acting through the IL-1RA receptor. We also performed a couple of other studies to see that they are bringing down the inflammatory cytokines, and then we went ahead to the pharmacokinetic and the pharmacodynamic studies. We observed a substantial increase in the pharmacokinetic parameters like T-half. For the free IL-1RA, it was 5.7 hours, which increased to 33 hours with the nanocomplexes. Likewise, there was an increase in the AUC and also an increase in the Cmax, which shows the potency of the developed formulation. And then we went ahead to evaluate the anti-diabetic activity in the streptozotocin-induced diabetic mice. We see that while in case of diabetic control, the level of blood glucose was around 400, it was brought down by IL-1RA nanocomplexes, and the body weight was substantially maintained, which was quite low in case of blank and free IL-1RA. It was also able to reduce the level of inflammation, as we could see by decreasing the level of IL-6 and TNF-alpha. This is the histopathological studies. By HME, we found that the level of beta cells was quite high, similar to the normal cells, and a very high level of insulin production was seen, which was further quantified by MHJ. This is the level of insulin in normal animals, which gets substantially reduced in diabetes, but is quite increased when the rats were administered IL-1RA nanocomplexes. Not only that, it also reduced the inflammation of pancreatic beta cells, which we can see here by reduced infiltration of CD8 plus and CD4 plus T cells. And again, this work has been patented and it has been published in Advanced Healthcare Materials. The work has also been acknowledged by a couple of awards by CRS, including the HL Bhalla Award as well as the Best Thesis Award for the student. And with this, I would like to end my presentation, thanking all my collaborators, my wonderful students, and all the funding agencies for supporting the lab generously. Thank you.
Audience, any question, please? Thank you, madam, for giving the nice lecture.
And we must compliment you, for such a exhaustive and very productive work which is translational. So my word of advice to you, since you are working in drug delivery, and today even the pharmaceutical industry, if you wish to translate they also wish to take the laboratory knowledge to industry, translate to them, is through, QBD, quality by design systems. So I do not recommend the entire QBD to be implemented at lab scale, but at least the DOE must be initiated. The kind of studies which you are demonstrating for those, if you tend to apply DOE, you'll see remarkable change in the output, which will be positive one. Your outcome of formulation will be much more productive, because we are here by ignoring the interactions which could otherwise be. And one another query is your last formulation, half-life got tremendously increased. AUC increased is understood. The Cmax increase is understood. The T-half augmentation by many folds. So it sounds like the effect is somehow drastically sustained. The relativity is so that must have been discussed in your publication.
Yes, sir. So the main reason is that when we are giving any of the protein or peptide naked, they are very prone to metabolism and degradation, due to which they have a very short half-life. If I talk about C-peptide, it is secreted along with insulin. It has again a very short half-life. But when we are complexing it, because it is no more naked, it is not available readily for metabolism. Secondly, as you already said, it is being sustained. So only the portion that gets released, that is exposed to metabolic enzymes. Slowly and gradually, as it is getting released, that is what sustains its life in the blood.
Have you calculated the AUC also there? We are not showing that.
Yes, sir. I showed AUC, sir. We calculated all the PK parameters, sir.
But that Cmax has been tremendously improved.
Sir, yeah, the main improvement what we saw was in T-half. Yeah, T-half substantially improved.
Availability is increased and the sustenance is increased.
Yes, sir. Both have improved. So the purpose was, sir, that it should. Yes, sir.
Inhibition rate constant?
Yeah. Yes, sir. I did not show that, but we calculated all the parameters, and the purpose was to make it sustain in the body so that the frequency of dosage could be brought down, looking into the cost of these therapies. So if we are able to increase the T-half, and we would be able to sustain it in the body, and thus we would be able to bring down the frequency of administration.
I'm sure you must have used compartmental kinetics.
Yes, sir. Yes, sir. Yes, sir. We use compartmental kinetics for this.
Thank you. Thank you.
Thank you. Thank you.
Thank you so much, Dr. Mittal. Again, I would request Chairperson to please felicitate Dr. Mittal. Please join.
Our privilege.
My privilege.
I listen.
Chairpersons, please introduce the next speaker for the day.
The third speaker is Dr. Hinpreet Kaur, who is a professor in pharmacology at SBB School of Pharmacy and Technology Management at NMIMS Mumbai. She holds M.Pharm in pharmacology from University and a PhD from NMIMS, both prestigious institutes, where her research centers on neuropharmacology and metabolic syndrome, respectively the effects of nutraceuticals and herbal medicines. For more than 16 years of academic experience, she has led major projects such as SERB funded work on neuroinflammation in Alzheimer's and published widely. She has nearly 100 papers and nearly 30 book chapters, while mentoring humorous and pharmacological. Welcome, Dr. Kinsley.
Thank you, sir. Thank you for asking. Thank you, sir. Thank you so much. Yes,
As
sir.
two speakers
Yes,
have
yes,
already,
yes. I will take consideration. Yes, sir.
submitted.
So, very good morning to everyone. The topic of my presentation is drug repurposing strategies for Alzheimer's disease, a futuristic approach for Viksit Bharat. So, to begin with, as we all know, Alzheimer's disease is one of the most common neurodegenerative disorders, which is characterized by loss of memory, behavior changes, language impairment. So many people are suffering. Right now, 55 million people are suffering from the dementia worldwide, and the number can increase by 130 million by 2050. So there is an unmet need to search new drugs for the same. Because drugs are available, if we walk upon the pathophysiology of Alzheimer's disease, there are so many reasons like accumulation of beta-amyloid plaque, tau formation, neuroinflammation which is happening, and there are drugs are available, but they cannot cure the Alzheimer's disease. So you can see there are so many drugs are there, donepezil, glutamine, rivastigmine. These are the drugs which can actually be used for the treatment of Alzheimer's disease by reducing the formation of amyloid plaque, tau phosphorylation, neuroinflammation which is taking place. So for the treatment of Alzheimer's disease, what we thought, like if we take upon the drug repurposing strategy, it can be a cost-effective approach and innovative approach for treating the Alzheimer's disease. So that's why the purpose of our study is to search more drugs which are coming into the market. How can we repurpose the drugs for the treatment of Alzheimer's disease so that they can reduce the formation of amyloid beta plaque, neuroinflammation, tau formation which is taking place. Because so till now, from the year 2003, very less drugs are coming in the market for the treatment of dementia. So these are the summary of drugs which are being repurposed. If we I will just take the names of this. Tamoxifen is there, clozapine is there, telmisartan is there. So that's the approach, that is the unmet need. So we thought that if we can repurpose a drug, it can save the time, it can be an effective approach for treating the Alzheimer's disease. So this is the work which we have done in our lab. So hydroxypyridine, that is an amoxicillin succinate. It is an iron chelator. So we thought how can it can use for the treatment of neuroinflammation and treating the Alzheimer's disease. Similarly, we have worked upon the bovine cholesterol, which is containing a rich source of lactoferrin. Then we have repurposed the calcium channel blockers in our lab. We have worked upon the antihistamine clemestine. We have searched upon the antiviral drugs and anti-inflammatory. These are the drugs which are studied in our lab for treating the Alzheimer's disease. Like we have also worked upon the natural supplements like beta vulgaris, which contains betaine, along with the virgin coconut oil. Similarly, we have worked upon the bovine cholesterol, which is the first milk which is obtained from the cow, because it is rich in immunoglobulin. So how it can be repurposed is for the treatment of Alzheimer's disease. So to begin with, clemestine, which is an antihistaminic drug, it basically reduces the neuroinflammation, reduces the oxidative stress, and improves the neural communication. So we have searched these drugs and we have found the use of clemestine in the LPS model. So in this case, if you can see that when we have given the LPS for 14 days and we have seen the effect of clemestine and we have observed behavior changes in that. So where the LPS was given in the disease control model, the time spent in the target quadrant was significantly decreased in the LPS, whereas when we have taken the clemestine in low dose and high dose, at the dose of 5 mg and 10 mg, it has shown the significant increase in these parameters. And you can talk about this NLRP3 pathway, it has also been reduced significantly by the drug. Then we have worked upon the oxidative stress parameters. We have seen SOD, catalase, glutathione were significantly enhanced by treating the drug, and the interleukins were significantly decreased at the low and high dose of clemestine. Similarly, we have seen the histopathological changes also. So we can see that there is a gross morphological changes which is taking place. When you talk about we have taken the hippocampus region as well as the cortex region. So there is increase in the density of the cells in the hippocampus when it was treated with the clemestine at the dose of 5 mg and 10 mg. So in the archives of pharmacology, we have published this paper also. Then we have worked upon the cycloparox drugs, which is an antifungal drug, which is also being repurposed for the treatment of Alzheimer's disease because it helps reduce the metal chelation, because accumulation of metals results in the Alzheimer's disease. So we have thought like how it can be repurposed. Similarly, this model was also taken in which the drug was seen the effect, the cycloparox was given at the dose of 1 mg and 2 mg and compared to the standard donepezil group. So we have seen that there was significantly decrease in the acetylcholinesterase levels when the cycloparox was given. Similarly, the GSK levels were significantly decreased by the cycloparox combination. So if you talk about the TNF, interleukin, because these are the neuroinflammatory parameters which is taking place. So when the cycloparox was given, they have shown the significantly decrease in the TNF, interleukin, CDK5 levels. So the improvement in the acetylcholinesterase levels were also seen. Decrease in the inflammatory markers were seen. So it can indicate that it can restore the cognitive impairment. Similarly, we have worked upon the bovine colostrum, which is rich in immunoglobulins. So to enhance its permeability, we have taken its combination with the borneol because it is an enhancement of penetration. So we have used aluminum fluoride model, which was given for the 42 days. So on the 21st days and 42 days, the parameters were checked in the Morris-Watermaid test. You can see that the time spent in the target quadrant was significantly increased when the combination was given, and toxicity parameters were restored. MDA level was significantly increased in the induced group, whereas the GSH catalase level was significantly increased. Similarly, inflammatory markers, if you talk about hippocampus and cortex region, inflammatory markers were significantly decreased in the combination group when the bovine colostrum was given in combination with borneol, which is a penetration enhancer, and the neuroinflammatory parameters were significantly decreased in F-kappa B. So this was the histopathological changes which was seen, the degenerative shrunken neurons which was restored when the combination of this drug was given. Similarly, we have worked upon the calcium channel blockers, where we have taken this CCB blockers. First, we have done its networking pharmacology. We have identified with the KEC pathway what are the pathways which are responsible for the induction of Alzheimer's disease, and the docking studies was seen. And based on these parameters, we have used basically treated these drugs and seen its parameter. This was a project which was funded by SIR, in which we have screened the amoxicillin succinate, which is an iron chelator. So for the first time in our lab, we have induced, in the zebrafish, we have induced iron induction model for the neurodegeneration, and we have seen how these parameters were significantly enhanced when the amoxicillin was given at the dose of 4 mg, 8 mg, 12 mg. Significantly enhancement in the levels were seen if you talk about the total distance traveled time, antioxidant parameters, inflammatory markers, and this work, if you talk about the acetylcholinesterase levels also, it was significantly decreased when the amoxicillin was given at the dose of 4, 8 and 12 mg per kg. And similarly, if you can talk about GSK level, NLRP3 levels were significantly decreased. So this work has been published in the Brain Research also. It is basically the self-funded project which we have done by my PhD student. And similarly, we have seen its effect on the rodent model also, where the aluminum fluoride was given for the 42 days. If you talk about the path efficiency was significantly decreased in the Morris-Watermaid test. And similarly, if you talk about the entry latency was significantly increased because when the amoxicillin was given, the memory restoration was taking place. And these parameters was further confirmed by the GSH level, which was significantly increased in the hippocampus region. Interleukin parameters was significantly decreased, NLRP3 was decreased. So it suggests that when the treatment was given with amoxicillin, it can able to reduce the neuroinflammation by reducing interleukin, NLRP3, MDL levels, and the significantly enhancement in the catalase GSH level was seen. And these are the histopathological changes. You can see there's a neural degeneration which is taking place, but was significantly reduced when the amoxicillin was given. So this is the last work which I want to say, that betaine was given in combination with virgin coconut oil. Similarly, we have seen that when the betaine was given in combination with the virgin coconut oil, it helps to restore the memory by reducing the neuroinflammatory pathway and increasing the levels of acetylcholinesterase levels were significantly decreased. So this is the work which is also being published in the our fish physiology and biochemistry, where we have done it in the zebrafish model followed by this model. So future perspective, so if we can repurpose this antihistaminic, CCB blockers, antivirus drugs, it can enhance the drug delivery costs and reduce the drug delivery costs for the treatment of Alzheimer's disease, because we have seen that these drugs can be further translated. Futuristic work need to be done in formulating these drugs. More amount of work is going in our lab, where we are working upon other different categories of drugs for the treatment of Alzheimer's disease. So we are thankful to BIRAC, DST, Ayush for giving us all these fundings, and thank you so much. I'm thankful to my student team also, has really worked upon this arena. Thank you so much.
We must again compliment you for an excellent and one of the most innovative kind of work on repurposing of the drug, and where you have not only tried to exploit the chemical drugs, you have also tried to look into the naturally acting natural substances like colostrum, bovine colostrum, and the virgin coconut oil. Kudos to you, and you are working on a disease which is plaguing the world. It's Alzheimer's. I must compliment you again.
Thank you, sir.
A word of advice, that we
Yes,
senior
sir.
professor, and you must make use of, you have used pharmacodynamics. So wherever possible,
Sure.
enzymes, pharmacokinetics, if you can
Brain
add.
penetration.
Yeah,
So we are
brain
delivering that.
levels,
Yes.
and
Yes.
blood levels and brain levels, if you could augment
Definitely,
that.
sir. We are working in that direction also.
Yeah,
Yes, we
that
do.
will certainly make it
That is very good
confirmatory.
suggestion. Yes, sir. Very
And
good.
so kudos to you. And if you collaborate with the two institutes,
Yes, sir.
from
Definitely.
where
I've got my friend also today. I will definitely.
NIBR and
Yes,
INSD,
yes.
I think the
Sure,
work
sir.
will be further augmented.
Yes, sir.
Kudos to you.
Thank you, sir.
Dr.
Thank you. Thank you, sir. Sorry, sorry.
Thank you. Thank you so much, Dr. Kaur. So I request our chairperson to please felicitate Dr. Kaur.
On 6th, I was there. He was telling that one of my niece
So humble request for chairperson to please introduce our last speaker for the session.
Thank you. So our next speaker will be Dr. Urmila Aswat, who is a professor in the Department of Pharmacology at Pune College of Pharmacy, Bharati Vidyapit, deemed to the University at Pune, with 10 years of academic and research experience. She specializes in preclinical pharmacology and drug discovery, having published more than 75 peer-reviewed papers and book chapters in international journals. Dr. Aswat's research focuses on experimental pharmacology, particularly on natural products and their therapeutic potential, including work on diabetes, metabolic and stress disorders, cardiac toxicity, and allergy genetic models.
Good morning, everyone. Good morning, sir. So this is under Viksit Bharat. I thought when the theme is Viksit Bharat, so I wanted to talk about where we can use Ayurvedic preparations which are very much less explored. And hepatic encephalopathy is one of the area where we can see that not many drugs are available. So the title for my talk is From Ayurveda to Modern Medicine or Modern Science: Evaluation of Herbomineral Formulation for Hepatic Encephalopathy using integrated in silico and in vivo techniques. So this is actually a reverse pharmacology project where we have Dr. Fondekar, he is one Ayurvedic specialist from Mumbai, and that study was taken forward in preclinical lab, from clinical to preclinical lab, and we were also supported by the Dr. Christopher Rose, who is a president of IPSCON. So he helped us to develop the animal model for encephalopathy. So hepatic encephalopathy is a syndrome of neuropsychiatric dysfunction caused by autosystemic venous shunting with or without intrinsic liver disease. So here the blood from the portal circulation gets directly into systemic circulation, and because of that there is lot of ammonia production in the systemic circulation which goes into the brain, and because of that there is edema into the brain. The symptoms includes mental and personality changes such as confusion, mood swings, irritability, cognitive issue, difficulty concentrating, memory loss, and motor problems. Tremors, poor coordination, slurred speech are also seen. So here I have given the representation where the ammonia, which is actually should get converted into the urea through the urea cycle, but during encephalopathy, this urea or the ammonia get bypassed because of photosystemic shunting and goes into the brain, where it is converted from glutamate to glutamine, resulting in cerebral edema. The same thing I have shown here, where I have shown on the other side the glutamine cycle.
So here we can see that the colonic bacteria or mucosal enzyme, they break down the digested protein and release ammonia. This ammonia should enter the portal circulation in a normal cycle. In cases of hepatic failure, ammonia accumulated into the systemic circulation, and this hyperammonia results in neuronal dysfunction because this ammonia goes into the brain, and into the brain, the other side I have shown this, here I have shown. So this ammonia into the astrocytes, it goes into the astrocytes, and with glutamate it forms glutamine, and this glutamine get accumulated, which leads to the hyperedemetic condition into the brain, and astrocytes undergo swelling, they get swelled up, and this leads to encephalopathy. Now these are the major symptoms, like I have shown the picture here, which is called as the asterixis or the tremor of hand or flapping of the hand. So here West Haven is the criteria which is normally used for hepatic encephalopathy gradation or making the criteria for it. So we have like stage 0, 1, 2, 3, 4, and normally these are so normally this is seen by, here we can see that the mild asterixis or tremors are there in the first stage, and then we have, if it progresses into the this is called as deciveric posturing, which is abnormal posture of the body. So these are different grading of HE, and the background of the study is that HE is highly prevalent disease, but not very it is less known because it is not reported. So in India also, this is the study which is shown in India, this one I have shown from India, the prevalence is 53 to 62%, and many of them, the cases are coming from alcohol-related liver disease. So this is mainly responsible for HE in India, but it is very less reported, only few paper I could get to report here. The treatment is also very less. We can see like lactulose and rifaximin. Lactulose is one of it's a disaccharide, and it absorbs ammonia into the gut and excrete it out. So that's only symptomatic type of treatment which we get. Rifaximin is again one of the gut selective antibiotic which do not get absorbed and remains into the gut and inhibits the gut the ammonia producing microorganisms or bacteria in the colon. So both these mechanisms are working by reducing ammonia into the systemic circulation. Now, apart from this, the reported intervention or used intervention, Ayurveda is also, or herbal medicines are also claiming some of them. Ashwagandha, then we have this the chrysine, and this ready leaf extract is also reported in hepatic encephalopathy in animal models. Now, when we talk about Ayurveda, so in Ayurveda, it talks about Yakrit Vikra, which is balancing the vitiated pit, kapha dosh, or eliminating toxins, which is called as Am. So the Ayurveda talks about the Yakrit Vikra or liver dysfunction, and it has given many of the medicines they have reported in Ayurveda, such as Virechna, Basti, then Arogya Vardhini Vati, then Tamrabhashma, and Punarnava. So these are one which are reported, but as I told you that this is the study where we have taken the Tapyadi Loh, which is a herbo-mineral formulation, which is already used at clinic, but it was never scientifically validated, and that's why we took this the formulation, and this includes Triphala, then Vivrtiki, Amalki, and so many medicines are there in this. Now this has already been reported in Charak Samhita, but the use is reported in Ashtang Hriday, and that's why we have taken this. The study plan was standardization of this formulation, followed by in silico and in vitro analysis, and then validating in vivo model. We have used network pharmacology in this, molecular docking, then MTT, DPPH assay, therapeutic model like TA, thiacetamide induced, and BDL, where we have done the surgery. Now, this is the standardization according to CCRS guideline. Here we could see that the formulation which was made at our clinic was under the as per the guideline. We also did TLC marker for many of the phytoconstituents which are present in this formulation, like gallic acid, quercetin, ascorbic acid. We also did LCMS and MS for quantification, and so we could see that this formulation had the markers like gallic acid, quercetin,
So the summary of analytical analysis, whatever we have done, includes foreign matter, ash values, Basma parameters as are at par with the guidelines given with the CCRS. The marker compound which could find is gallic acid, quercetin and ascorbic acid. Now the next was network pharmacology, where we could see that the 437 are the common targets of hepatic encephalopathy as well as Tapiadilo or TL. Now the top 25 gene which we identified using network pharmacology included albumin. So albumin is majorly it is synthesized by the liver. So definitely it is getting affected. Other than that, we also could see TLR4, inflammatory markers like NF-kappa-B, IL-6, MAPK, all these were involved. We also could construct the network of TL and HE using cytoscape, and we could see that they are highly connected. And this is gene ontology, where we could see that this network is indicating the involvement of hepatic encephalopathy or hepatitis in with this drug. KET pathway told us that this drug can be used by targeting NF-kappa-B pathway, TNF alpha signaling pathway, toll-like receptor pathway. So we found the important targets where we should work further. Then molecular docking, when we did, we could see that gallic acid, quercetin and all those markers which we found were actually having the effect on TLR4, NF-kappa-B, TNF alpha, interleukin 6, interleukin 1 beta and so on. So we could see that there could be the multifactorial effect of this preparation. Now, so this is the discussion of network pharmacology. We could see hepatoprotection, anti-inflammatory modulation and cell death and survival through mTOR and TP53, which these studies are going on. So KET pathway indicated the formulation could promote the liver cell survival, suppress the chronic systemic neuroinflammation, and it can improve the dysregulated cellular metabolism associated with chronic liver disease. So these were the results from the in silico experiment. Then we performed the in vitro experiment, where we could see that the TL was it was able to, when the cells were Hg2 cells were used and when they were insulted, insult was given by TA, that is thiacetamide, we could see protection for these cells by TL. Further, we did in vivo studies and we developed two models. One was type A and type C. Type A, where we have used thiacetamide, and we can see that it clinically correlates with overtype of hepatic encephalopathy, and type C correlate with the cirrhotic type of where the hepatic encephalopathy is associated with cirrhosis. So bile duct ligation model was used for that. Thiacetamide, these were the groups where vehicle control, disease control, lactulose, tapadilo, two dose we selected on the basis of acute oral toxicity. We conducted a behavioral assessment on 22nd to 24th day, and biochemical analysis, histopathology and gene expression study. This is a bile duct ligation, where we could develop this model with the formula which I just said. Here also we had these group, and lactulose was used as a standard here, which is normally prescribed also. The results showed that the CNS parameters were they were affected in TA, that is thiacetamide induced liver hepatic encephalopathy, whereas TL20 and 40 were able to protect it. The biochemical parameter also, the major parameter was plasma ammonia and brain ammonia, which we developed at our lab, and we standardized the process. So we could see that ammonia was very high in TA model, and in TA group, and in brain ammonia was also very high. Lactulose and other treatments were able to reduce it very significantly. And other parameters of liver were also normalized, like AST, ALT, total protein, total bilirubin and direct bilirubin. Similarly, in BDL induced, where we have done the bile duct ligation, the ammonia level was very high. We could see in BDL model, which was more than that of the TA, that is thiacetamide. This is happening because we have constricted the bile duct, and because of that, the ammonia is getting retained into the blood and going into systemic circulation and then into the brain. Again, here we could see that TL was able to reduce or normalize these. The pro-inflammatory mediators, the pro-inflammatory cytokines which we got from network pharmacology, when we estimated, we could see that in brain as well as in liver, these were high in disease group, whereas they were reduced in the treatment group. Similarly, in case of NF-kappa B, which was again one of the major target got from necropharmacology. BDNF is also a neuroprotective, which was reduced in the disease group and improved in other. This is again the BDL model, also similar type of results were obtained, which is bile duct ligation. We could see that there is a protection given by the formulation. Then on pro-inflammatory mediators in brain and liver, here also on NF-kappa B we could see the similar effects. On BDNF also we could see similar effects. The major TLR4 pathway which we could obtain from network pharmacology, we could see TLR4 expression was increasing in the disease group. TLR4 is responsible for activation of NF-kappa B as well as further increasing the level of pro-inflammatory cytokines. So here we could see that the formulation was able to inhibit it. The same, whatever the results which we were obtained in biochemistry were supported by histopathology, and we could see that the liver as well as brain was protected by the formulation, and neuronal swelling was reduced by the formulation. So this is the bile duct ligation, sir. I'll just show, it's just a very short video, yeah. So this is the bile duct ligation, and here we could get the support from IPSCON lab, which is International Society for Encephalopathy. It's a hepatitis and neuroscience lab at Canada. So this is how the surgery was performed, and bile duct ligation was done. So this process was standardized at our lab, and we could develop this surgery. So finally, what we could see, we can conclude is hyperammonemia is a major factor responsible for hepatic encephalopathy leading to astrocyte swelling, and in this ammonia increases in the brain as well as into the plasma, and we could see that TL treated group reduced it. This was supported by the behavioral parameter like open field test, where the locomotor activity was assessed, EPM, where we can see the learning and memory, so which get deficit in the HE, whereas this was improved. As well as we also see the effect on open field test and cognitive benefit from the formulation. Again, liver function test, antioxidant parameter, histopathology, all were found to be in favor of the formulation. So the increased level of NF-kappa B, TNF alpha, interleukin 1 beta, as well as BDNF was normalized. So finally, in our disease, in drug group, down regulation or inhibition of TLR4 was found, which is responsible for preventing them. It prevents the astrocyte to become inflamed or activated because of high level of ammonia. Second pathway was MAPK pathway. So we found that it inhibits MAPK pathway through NF-kappa B, and that's why the inflammation and the stress in astrocyte was reduced. As well as the edema was reduced because of direct effect of TLR4 and other inflammatory cytokines. So final results are the formulation reduced neuroinflammation, astrocyte swellings or stress signals, cerebral edema was reduced, and overall the neurological function was improved in the rats. The work was accepted at IPSCON 2025, and we acknowledge that, and the work is also accepted in JAIM journal. We acknowledge Dr. Fondekar, who told us about this formulation, and he was able to treat some of the patients with this formulation, and that's why we went for reverse pharmacology approach. Dr. Christopher Rose, who is the president of IPSCON, who helped us to develop this model in our lab, and I also acknowledge IPSCON 2025 Punjab University for giving me this opportunity to show this work at this platform. Thanks a lot.
Any question from the audience?
He's working on a project which is the need of the hour for the country, because we have got very rich legacy of the herbal drugs, be it Ayurveda or Unani or Siddha medicines. And if you compare this with the TCM, so the basic issue is sterilization and the use of drug delivery systems on the herbal formulations per se. So what do you see, the future of this, amalgamation, the trend, the modern technology and the herbal drugs? You know, what is the point that single couple of points, you know, which are needed to bridge that gap,
Yes.
much needed gap?
Yes. So definitely, now we have so many modern technologies available, where right now we can actually study Ayurveda in a very detailed manner. So we, as I said that, you know, we have very good standardization procedure. So we are doing that. I think a lot of work is going in that area, as well as then we have some network pharmacology approach, or any computational aided drug designing approach. So we can use that. Then thirdly, also we have so many the in vitro techniques, where we can do some type of studies, and which can be validated using the in vivo model. So definitely our lab is also involved. We have recently also received a grant from our Ministry of Ayush, where we are doing some studies related to Alzheimer, and we are doing using the same approach, where we are exploring the medicine in all the ways, so that we can give a very in a broad aspect, we can give this scientific proof for these drugs, which are very much less reported.
I think we need to learn a lot from the experiential wisdom of
Yes, that is very
ECM
much
and
needed.
Japanese medicine,
Yeah.
which are thoroughly explored and very frequently used in their respective countries,
Yes,
with fruition, with success.
definitely, sir. Even I was surprised when two things for this project I could not find was, first, the prevalence data of because we know that alcohol is very common in India, but we could not see when this type of alcoholic people goes into encephalopathy. So how much is the prevalence data? So that we could not see any. And second thing was, the drugs are not there for encephalopathy. Still, so that's why that was the reason that why we went for this project. Thank you.
Thank you so much, Dr. Urmila. Please take care. I would request our chairperson to please felicitate for her wonderful presentation. Thank you. So now we take a moment to express our gratitude towards our chairperson of the session, Professor Bhupinder Singh Bhoop. So thank you so much for sparing your valuable time. We would like to felicitate, sir. I would request Professor Mary to please join, Professor Jayaprakash to please join for the felicitation. Are you, sir? We also express our gratitude towards our co-chair, Professor Sangamar. Thank you, sir. Thank you so much. So with this, we proceed towards our second session for the day. It's my huge privilege to introduce our chairperson for the second session, Dr. Jayaprakash. Dr. Jayaprakash is a senior principal scientist officer and officers in charge, National Coordination Center for Pharmacovigilance Program of India at Indian Pharmacopoeia Commission. Ministry of Health and Family Welfare, Government of India, Ghaziabad. He was also Secretary cum Scientific Director IPC. He has overall more than 20 years of experience in the area of teaching, research, pharmacovigilance, pharmacopoeia and formulary science. He has been temporary advisor expert for the WHO expert committees, Geneva, Switzerland. He is a member of National Expert Committee for Allergens, member of Institutional Human Ethics Committee, National Institute of Biologicals, Noida, Multidisciplinary Expert Committee for National Pharmaceutical Pricing Authority, New Delhi, and the member of International Society for Pharmacovigilance. Also served as a member of Core Group of Revision of National List of Essential Medicines 2011, 15 and 22, and member of CDSCO Expert Committee for DRICE Test. He has several publications to his credit in books. He has 16 chapters, national and international journals, more than 22 nationals and 18 international publications. So please grace it us. I would also like to invite a chairperson for this session, Professor Vikas Medhi. Dr. Medhi is a professor and ex-additional medical superintendent in PGI-MER, Chandigarh, the Department of Pharmacology. His area of expertise is experimental pharmacology, clinical research, regulatory pharmacology, development of nanoformulation, pharmacogenetics, pharmacogenomics, and stem cells research. He has more than 25 years of teaching and research experience and has earned more than 65 national, prestigious, and international awards. He is a core panel for expert for the task force in IND applications and regulatory affairs, lead GLP inspector, lead GCP inspector, principal assessor of NABH. He is involved in several committees of DCGI office, ICMR, DBT, DST, CSIR, and BMSI. He has authored 5 books and more than 160 chapters and published more than 500 articles in national and international journals. He was also selected as a member of various central government committees, Central Working Group of Pharmacovigilance, Single Review Committee. Dr. Medhi is a part of COVID-19. He was a part of COVID-19 task force, and he has many more accolades to his credit. So please grace the dais. I would request our chairperson to please introduce our first speaker of the session, Dr. Shashi Bhushan.
Good morning, everyone. Good morning, everyone. So, at the outset, I thank Dr. Anil for inviting us to this important symposium on vigilance of medical products. And we have 4 speakers in this session. And I request each of these speakers to give their speech within the time limits of 15 to 17 minutes. So we have our first speaker, our colleague, Dr. Shashi Bhushan. Dr. Shashi Bhushan is Senior Scientific Officer at Indian Pharmacopoeia Commission, and he has more than 20 years of experience in research in the area of drug discovery and development of novel anti-cancer drugs. And he is also looking after the pharmacovigilance activities at Indian Pharmacopoeia Commission. He also has the interest in development of herbal drugs, monographs, botanical reference standards, and he has also worked in the area of cell signaling pathways involving in apoptosis, autophagy, angiogenesis, pharmaceutical formulation design, and pharmacovigilance. So with this background of Dr. Shashi Bhushan, I invite him to give an overview of the pharmacovigilance program of UNIT. Welcome to you.
Thank you, sir, for a wonderful introduction. First of all, I'm thankful to the organizers for providing me the opportunities to give a talk on the pharmacovigilance program of India, powering patient safety across the nation. What is pharmacovigilance? It's a combination of two words, pharmacon and vigilian. Pharmacon means drugs and vigilian means to keep watch. So in the simple word, pharmacovigilance is to keep watch on drugs, and as per WHO, it is defined as a science and activities that is related to the detection, assessment, understanding and prevention of adverse effects or any other medicine-related problems. And these other medicine-related problems may be medication error or lack of efficacy or other quality issue of the drugs. So why we need pharmacovigilance? As you know that during the clinical trials there is a lack of safety data because it was used for the narrow indications, lack of solution times, especially the groups like children and pregnant women are not part of the clinical trials. So pharmacovigilance is basically real world data. And secondly, the IDRs represent a silent but quick leading cause of death. In the world, it's a very huge economic burden for a country. Like in the US, it costs around 177 billion expenses per annum, and ADR also goes near about 5% hospitalization in India. It's around 1/3 of ADRs are preventable by preventing the medication errors, and pharmacovigilance promote the basically rational and safe use of drugs, so by which we can continuously update the package inserts, issue the drug alerts, and find out what is the different benefit and risk profile of the drugs. So as a consumer perspective, it boosts public confidence, and as a physician, it provides the new information on the drugs. So now question arises, pharmacovigilance for how long? As you know that the safety issue of a drug can be arise at any time, whether it's preclinical to phase 1 to phase 4 or after the post-marketing. So therefore we have to do the pharmacovigilance throughout the life cycle of the drugs. Coming to the Indian perspective of pharmacovigilance, we have more than 1.40 billion populations with different ethnic diversities. We are using different types system of medicine like allopathic, Unani, Ayurvedic, mixture of both. So there are chances of drug-drug interactions, and moreover we are world of pharmacy and mostly we using the fixed dose combination. It is a combination of 1 or 2 drugs. So that basically increase the risk of producing the side effects. And Indians are prone to more than 5.6 lakh signal nucleotide polymorphism that basically affect the pharmacokinetic and pharmacodynamic of the drugs, and that ultimately affect the adverse effect reaction of the drugs. So you can say that Indians are more prone to adverse reactions, and therefore we need an indigenous adverse reaction database of Indian peoples. So on this preface, Government of India has launched this program, that is Pharmacovigilance Program of India. It was launched in 2010, and AIMS New Delhi is the National Coordination Center, and it was shifted to the Indian Pharmacopoeia Commissions in 2011, and IPC is working as a National Coordination Center for Pharmacovigilance Program of India, and it's a very open system for collecting and analyzing the adverse effects received across the country. And the main objective of PPI is the patient safety and to outreach across the country. And it's also ensure the benefit of use of medicines outweigh with the risk associated with its uses. IPC is also working as a WHO Quality Center for Pharmacovigilance in Public Health Program and Regulatory Services. This is the Pharmacovigilance Act as rule. As per the Schedule M of Drug and Cosmetic Acts 1940 and rules thereafter, it is mandatory to report severe advertisements to the concerned licensed authority by the manufacturers. Second, as per the new drug and clinical trial rules 2019, it is mandatory to set up a PV system in industry and to report the periodic safety update reports to the CDSO, that is our National Regulatory Authority. And as PV is also one of the subject in pharmacy undergraduate curriculum, and moreover the PV is a key indicator for the NRA assessment as well as the NABH assessment at the time of their audits. So from where we get this data, these are all mainly 4 main stakeholders. We directly get the reports from the patients or the consumers. We get the reports through our different national coordination centers like PV centers or NICO centers and other organizations. And around 1/3 of report we get from the marketing authorization holder, that is the pharmaceutical industry, as per the Schedule M and Schedule as the NDCT 2019 rules. And we have a robust system of different ADR monitoring center across the country. These ADR monitoring centers are basically the medical college and hospitals that are working for the PPI. They're sending the reports to the PPI. So now question arises, what we have to report? We have to report every kind of reaction, whether they are known or unknown, it is serious or non-serious, whether it is very common or to very rare reactions. So we have to report every type of reactions through the any type of products, like maybe through allopathic, Ayurvedic, vaccines, medical devices, blood or blood-related problems, areas due by the drug withdrawal dependencies, and areas due to the medication errors, lack of efficacy, or through the off-label use of the drug. So we have to report every type of reactions or any type of conditions. So who can report? Both the healthcare professional and non-healthcare professional can report these areas to the PPI, and they are basically our eyes and ears of successful systems. Industry can also report as per Schedule M and NDCT rules. And different authorities like different national programs are also reporting to the PPI. So question arises now how to report. These are the 5 main channels of ADR reporting tools. One is our ADR PPI 2 mobile app, that is Android based, freely downloadable from Google Play stores. Second is our helpline number 1800-180-3024. It's working from the Monday to Friday in our working day, and after that we have an interactive voice recording system that is available on 10 different languages. We have system of ADR reporting forms. You can fill this form and submit to this email ID or submit to the nearby ADR monitoring centers. These are basically medical college hospitals. And last is the ADRMS, Adverse Declaration Monitoring System. It's a type of online reporting tools. You can directly log into that software and submit the ADRs. This is an example of our toll-free numbers. Is available in 10 different languages, and some medical college hospital also embodied these toll-free number in their OPD and IPD slips. These are example of ADR reporting forms, and these are the expansion of our ADR monitoring center across the country. Right now we have 1120 ADR monitoring centers, and with 333 are governments and non-government are 787. These are state by the MC, and almost every state we have ADR monitoring centers, and our next target is to find out these AMCs in all the districts of India. This is simple procedure of AMC enrollment. The target group is any hospitals. They can form a AMC enrollment form, submit to the PPI, and these are some basic logistic requirements that they have a dedicated area to find out the carry out the activities of PV and some basic amenities like computer, internet, and scanners. So what are the advantages of being an AMC? You are part of a nationwide AMC reporting system. You have access to the Vigiflow, Vigilance, ADR database systems. You can do case studies. You can do the scientific publications. You can do the projects that is like to pharmacovigilance. Moreover, we are providing to the financial incentives to the AMC in the form of human resources as well as to the expenditure during the happening to the training, workshop, or conferences up to the 80,000 per annum. This is an example of our ADR online portals, ADRMS, and you can also scan this QR code and report that through the ADRMS. So this is how the data flow in PPI. We receive the ADRs from different our stakeholders, consumer, patient, industries, AMCs, and any other organizations. We collect and collect and analyze these ADRs and submit to our experts panels like signal review panels. They will find out what are different alerts, signals, or changes in the leaflets, package insert leaflets. Then we submit to this data to CDSO, our NRA, for any regulatory intervention actions, and also disseminate these reactions to our different stakeholders. So these are the basically 4 minimum requirements to report ADR. This one is the patients, identify reporters, and one is drug, and last one is the reactions. This is the status of different cases, individual case safety reports that we have received. And right now we have more than 10 lakhs ICSR in WHO database systems. We are in the 8th largest reporter of ICSR in WHO database systems among the 182 countries members. and we are third largest in the Asia. So coming to the quality of these reports, our quality score is very much high as compared to the rest of the world. Our quality score is 0.78 out of 1, while the rest of the world is around 0.54. Basically, physician is the 50% reports we receive through the physicians and 23% from the other healthcare professionals. These are some outcomes of PPI. We have issued 183 drug safety alerts, 66 changes in the packaging leaflet, 16 signals, and these are some examples of our signals. Signals are basically new drug ADR combination. It doesn't know anywhere in the world, and we are first time reporting this type of drug alert combinations. We have collaboration in different national programs, and TAP, NAPO, AFI for the COVID vaccines and other type of vaccines. And training is one of core mandates, and we are conducting several type of trainings at AMC and MCC levels, starting from the skill development program, interactive meets with the industries, and NUH hospitals. We are celebrating the National Pharmacological Week from 2021 onwards, which was celebrated in September 17 to 23rd every year. And we are also conducting international training programs such as Asia Pacific training programs. These are examples of some regional training centers, and PJ Chandigarh is one of the RTC working as in the PPI. So we have conducted around more than 12,000 training programs, and in this training program, more than 8 lakhs healthcare and non-healthcare professionals were sensitized about the pharmacovigilance program of India. This is our some example of PPI resource materials, like the guidance document for the consumers, how they report, guidance document for the industry, how they report to these areas. We have quality manuals for the effective implementation of quality management systems under the Pharmacological Program of India. These are some examples of posters which disseminate to our stakeholders in the area of pharmacovigilance. And this coming to the challenges for the PPI, we are the biggest challenge is under-reporting, and the reason for that is the lack of interest, lack of time. Sometimes physicians hear about what is the legal issues with the reporting, and other sometimes they require financial incentive or other type of criteria. We have lack of state human resources in pharmacovigilance. Moreover, we have not had any MCs in all districts of India. And coming to the less stringent PV rules as compared to the other US and European countries. So these are the highlights and achievements of PPI. As you say that more than 1100 area monitoring centers, submitted more than 10 lakhs ICSA and WHO database, 8 is in the world and 3rd in Asia. More than 12,000 training program, and more than 8 lakhs healthcare professionals are trained in PV. We are also working as a national WHO collaborating centers in public health program and regulatory activities. So in conclude, I just want to say that till date there is no safe drug, and no safe drug is coming in near futures. Every drug has adverse effect, and ADRs can be happen to anyone at any time, at any place, at even the right time, right dose. So it is a very huge economic burden for a country. Around 1/3 of ADRs are preventables, and every single report can make impact and save life of billions. And there are several ways of ADR reporting, like forms, helpline number, mobile app, emails, and other ADRMS online reporting tools. PV basically promotes the rational and safe use of medicines, and as a healthcare professional, it's our moral or ethical duty to report the ideas to the PPI. So by this note, thank you everyone for being with us. Thank you.
Thank you, Dr. Sasti. We can have 1 or 2 quick questions. Anybody has any questions? Go ahead. Can you give a mic?
No, it's okay. So the question is, sir, like you said that to report any of the drug adverse events, right? The question is, like if you have a person has consumed some food, and at the same time he has consumed some paracetamol. So the effect is because of the food rather than because of the drug. How would the normal person would attribute that it is because of the drug, not rather than because of the food? How we are going to differentiate that?
See, PBPay is a big program. You know, it's because of the drug. You have the pharmacovigilance, hemovigilance, metrovigilance. So there is a branch called nutritional vigilance also. So if any idea comes because of food or food additive, so you can also report. Okay?
So as a common person cannot be differentiated.
Common person will report, We have a committee, we make a causality. Is it because of the drug? Is it because of some other factors? We'll make a causality. So every center we have a causality assessment committee. And when it goes to IPC also, we make an assessment. So it will be critically analyzed. And even somebody reporting, whether this report is authenticate or not, we call the neighboring area monitoring center to verify the data. That is also. I think you have any. Yeah.
Good morning, sir. We all are well aware of the revised schedule that from the industrial side, from corporate quality managers, from Concern Pharma. My question is that earlier, currently, we are reporting the market complaint handled by the quality team. But now the ADR reported by the Pharmacovigilance department is separately. What is the minimum requirement? Is this B Pharm is okay or masters is required? Or MBBS हमें हायर मतलब डिपार्टमेंटल में लेना पड़ेगा या किसी से कॉन्ट्रैक्ट पे?
I think if you look at the gazette notification, it says that company will have to create a pharmacovigilance cell. So for pharmacovigilance cell, then you need an expertise of pharmacovigilance. Okay? If somebody M.Pharm having a training in pharmacovigilance, they are working in an industrial area, so you can report them.
Oh.
And they'll be reporting. Yeah.
So you are talking about the PV officer in charge at industry.
Industry.
Yeah, I think B Pharm is necessary for that.
But they should have an experience.
Yeah.
Okay.
On, you cannot just recruit. You can recruit. You can train them.
What is Upasala Monitoring Center?
UMC actually WHO wanted to have a collaborating center, and they requested Sweden government give us a place, and this place was given to.
So Indian government has to report all the pharmacovigilance data.
So it is like when we started in 2010, 15 July, we use a busy flow, that software. So our data goes to WHO, UMC, but we have an agreement that we have a fire shield. Nobody can use the data unless we give a permission. Okay. But we have also an coordinating center for ASEAN countries. We called a meeting in 2015 where 150 countries came, and then we got a center for collaborating center, Dr. Jayaprakash coordinate, and Dr. Kalai, and we train all the ASEAN countries. So that's how we.
So this data is shareable.
Extended to another 4 years.
So data is shareable.
Yes, yes, definitely.
Let me just add to it what Dr. Vikas Mehti has just told. India is the member country, is the member states for the WHO program for international drug monitoring, and there are more than 180 member states under the WHO program for international drug monitoring, and at the global level there are 3 such collaborating centers in the area of pharmacovigilance and public health programs. And WHO Uppsala Monitoring Center at Sweden is one such center. Okay. Another center is for the safety of vaccines or safety of, or the pharmacovigilance of vaccines in Spain. And third one is our center is the WHO Collaborative Center, which we have maintained since 2017 and already completed 2 successful tenures of 4 years each, and we are now in the 3rd tenure. Thank you.
Thank you.
Thank you so much, Dr. Bhushan, for a nice, informative talk. I would request our chairperson to please felicitate Dr. Bhushan. So please join. Rajat sir, please join. I would request Professor Rajat to please join. Thank you, sir. Thank you so much. So now I request our chairperson to please introduce our next speaker for the session.
So we have our next speaker, Professor Vikas Mehti, and Professor Vikas Mehti is a well-known figure in the area of pharmacovigilance as well as in pharmacology. So he is Professor of Pharmacology at PGI Chandigarh, and he also looks after the ADR Monitoring Center of PVPI, and his center is also the Regional Training Center of Pharmacovigilance Program of India. And his biodata has been already told quite in detail, so without wasting the time, I just welcome my co-chair, Professor Vikas Mehdi, and to tell his experience related to pharmacovigilance as he is maintaining the regional training center at PGI. Over to you.
Yeah, thank you very much.
Thank you.
Good morning, everyone. I said good morning. I went to next hall, and this hall particularly, it's a very good place to sleep. Are you agree with me? Okay. So in pharmacovigilance, first thing is alertness. Okay. If you are not alert, so you may not be able to report. And second thing is, for common people say you have a pharmacovigilance system, you can report. But it is important to tell them also, if you report, what is going to happen next. Because everybody wanted to have an output. I'll just take you the story. Dr. Rahman is sitting here. We started, including our India's name in pharmacovigilance 1998. I remember Dr. JP and myself were in All India Institute of Medical Sciences. HOD came in between the seminar. After the WHO meeting, he asked everyone, anybody heard of pharmacovigilance? So, 1996 or 1997, we didn't heard about pharmacovigilance, very few people. But today, fortunately, almost all B.Pharm student, M.Pharm, MD student, at least they heard of pharmacovigilance. But it is way going, pharmacovigilance. If I look back, 1982, we had a program. Vijay was one of the center. And during that time, couple of central government hospitals were included. But that program ran till 1988. Then, as I said, Dr. Rahman is sitting here. Dr. Singhal, he started an ad hoc project from ICMR, 1989, 24 centers. And that also continued for 3 years. But fortunately, I can say that, we collected 58,000 database during that time. Then we got a money from WHO, World Bank, and government launched a program, that National Pharmacovigilance Program, in 23rd November 2004. But it also continued till 2008. So, 2009, we had a meeting in All India Institute of Medical Sciences under guidance of Dr. Y.K. Gupta. 2 days continuously meeting, So during that time, we discussed, all this program, it is on and off. So we need a sustainable program. And during that time, we went and approached Health Minister that, this is our own program. Nobody is going to give money for our program. We have to create our financial assistance. And that's how 15 July, we launched a program called PVPI program, Pharmacovigilance Program of India. And it was started with 22 centers. Today, you can see it's the largest program. More than 1,000 centers are included. Largest program in the world. Subsequently, 2011, our DCJ had gone to Paris. And somebody asked him a question, do you have a hemovigilance program? And incidentally, he also came out of the room and Googling what is hemovigilance program. But one great thing is, once he come back to Delhi, he started a hemovigilance program. I was a co-member. Then Incidentally, there are a couple of incidents happened. Baby was kept in an incubator in Kolkata. Low birth weight baby. You need to maintain a temperature. Baby got burned. Subsequently, in Patiala, Musirabad, series of incidents happened. So the question was raised in the parliament, is our devices, whether you use for diagnostic and therapeutic devices, how do you maintain the quality? So we started a program of material vigilance. We wanted to start a program biovigilance because stem cell biologics, these are all patented since 2014. Then we have other programs going to initiate like cosmetovigilance. All of us, we use cosmetic. How many of you, report the cosmetic adverse event? We have a problem. Government had asked me to investigate when you go for a cup of tea, if somebody use, do you like to have a sugar free? You always say, I want you to have a sugar free. So we could find that in India, there are 18 artificial sweeteners, wherein, United States, they have only 4 artificial sweeteners. The problem came with artificial sweeteners. When you put it in hot water, you cannot give it to the pregnant woman because it's from the methanol. It cannot be given to children because it's from the methanol. It affects the cognition. And that's how we are asked to investigate. So there is another branch that's taken up is nutritional vigilance, vigilance. But one of these greatest one is, use of antibiotic. So I'm there in IND, Government of India, since 2008. I can tell you that only one drug has been approved as an antibiotic, is nephritomycin, in the last 15 years. So that means by 2050, we don't have any antibiotic. So there is a larger program, antimicrobial resistant program, because when you talk about adverse drug reaction, it is failure to therapy is also an adverse drug reaction. So for a student, you can say A, B, C, D. You can predict from the mechanism, but D is more serious and severe. All the drug has been withdrawn because of type B reaction. And when you give continuously the drug type C, D is delayed, E is end of therapy, and F is failure. Now, my job is to how you look at as a clinician, So we have already talked about pharmacovigilance, you detect, you make an assessment, and after assessment, your job is to, can I prevent it? Can I prevent it? Can I monitor it? And can I minimize? So this is how we have to go. So as you can see that all of us, we collect the report, send it to IPC, then it goes to Uppsala Monitoring Center. But we have a mechanism to train the people. Unless you train, I'll just give you an example. You go to psychiatry ward. You cannot directly talk to a psychiatry patient. Do you have any problem with the drug? You're not supposed to. You have to contact with the psychiatrist who is dealing with the patient. So there are formalities you have to follow, when you go to the clinics or you go to the OPD or you go to indoor. So this is how you can look at. So when you say that we understand drugs are evaluated, start from in silico, in vitro, proof of concept, all the regulatory toxicity study, then you go for a PMS. PMS means today you approve, because you call it a new drug, today you approve till 4 years, conventional drug, or till it is incorporated in Indian Pharmacopoeia Commission. So you collect the report 6 months till 2 years, and then up to 4 years, and that in a form of package insert it comes. So this is how we look at that ethics in PMS. If you plan for a phase 4 study, or if you go for a PMS. So this is also important in pharmacovigilance. Initially we discussed, should you go to ethics committee, get an approval that you're collecting that area, because you're collecting all the personal identity. Okay, so then you said that this is national program. As physician prescribed, you're going to collect the report. Then you talk about, final objective of vigilance, nutritional vigilance. So basically, if you look at that, when you work, like in PGI, we started a system. In India, you can only request a physician to report. Okay? But if you go to Netherlands, if a doctor does not report, they can initiate a legal action. Knowing the fact you are not reporting, they can initiate a legal action. But India it is totally voluntary. But in PGI what we did is, we took an approval from staff council. Moment anybody get admitted, then there is an ADR form. And at the time of research, they have to fill the form. So this is what indirect mandatory we have done it. So, you know that reporting ADR is usually a challenge that, under-reported. So if I take you an example, we always refer it to blue card system in Australia, yellow card system, med watch system. So if you take an example of yellow card system, one single man make a difference. His name is Sir Derek Dunlop. In 1963, he had written a letter to each and every doctor in the UK and dentist. And he said, this is the yellow card form. If you come across any ADR, please report to this system of Committee of Safety of Medicine. Today, it is a most successful system. And in recent time, when yellow fever mass vaccination was there in 2000, there is a huge report. And today also you can say that during the COVID time, we have a huge report. But if you go critically, their reporting rate is only 12%. So that means there is a huge under-reporting. So all hospitals, when you say in UK, only medical officer they report, no consultant they report. Okay, so this is how we have also problem. So definitely if you look at PGI, large institute, so if you go to different center, trauma center, emergency, dental, and Nehru Hospital, all these centers. So we get the report. So that means you have to go for a round. Normally we talk about spontaneous reporting. It is like morning I was here, somebody called me from OPD. There is problem in the OPD pharmacy. It looked like a fungus. This is spontaneous. But when you go for a round and you ask that is there any ADR, and you are going to tell, that is called the targeted spontaneous reporting. And we have a people, they go for a round, they ask a specific ADR, so that means we are practicing targeted spontaneous reporting. So if you look at the cardiac center, de-addiction, advanced eye center, new OPD block. But one more important point is I just tell you as a student, when somebody falls sick, if you go and ask, do you need anything? Can I help you? That gives a moral boost. Please remember, there is an emotional angle to it when you go to hospital. I'll just tell you one story, true story. I was an administrator for 10 years, so I used to call Milkha Singhji for any of the event, for creating awareness. So one day he told me that his wife was supposed to go for knee replacement surgery. And he came to know that Bishan Singh Bedi had already undergone knee replacement surgery. So he called Bishan Singh Bedi, should I go to that doctor? Bishan Singh Bedi said, he's a cricketer, early cricketer. Don't go to that doctor, he doesn't talk properly. You go to another doctor. So this is very important. How do you behave? How do you interact with a patient? Some doctors are very popular. I know one of my surgeon, he's an HOD now. One lady, every OPD she comes and say hello to doctors. And that is why it is very important to look at the politeness. When you go to clinics, even if you wanted to examine, can I ask you this question? Can I examine you? This is what. I remember one case, one patient came to my room. He wanted to say something. I said, you have a sit first, then we'll talk. And he became emotional. He said, you are the only person said, you sit first, then we'll talk. Otherwise, every time I go to anybody's room, hajja. So we need to improve our contact. Because as I see, in the OPD there are a lot of fight. Why there is a lot of fight? Because we don't have a contact time. We get 10,000 patients, that means one consultant will only spend 2 to 3 minutes. Within that, you take a history, detailed drug therapy. How can you tell them that if there is a problem? I'll just give you one example. You prescribe preform patient. You are going to tell the patient, don't get scared. If red urine comes, red tear comes, red sweat comes. That is known, it is predictable. And that's how we have to tell that how do you monitor? Sometimes there is an ADR and you directly ask the question, and then you find that this is an ADR. Person may not be knowing that, and you are going to record that. So this is very important. But if you look at that, we wanted to enhance the healthcare facilities, promote. And if I can reduce, because if you say that many patients, they go to many doctors, polypharmacy. When they come to the hospital, they have already undergone several drug therapy. And that is why it is very critically look at that. Is it because of the drug? Is it because of the drug interaction? Is it because of drug-food interaction? Everything you have to look at. So our number has been increased. Even when we started, I think 2013, I was in Geneva. That time, Sten Wilson was there. And they appreciate India. Because by that time, we collected 3 lakh database, and China had collected 9 lakh, but they could not translate into the English language. So we took an upper hand. Now we said that we are the largest, we have more than 10 lakh database. So this is very important, the challenge. How you can overcome the challenge. One challenge is underreporting. People may not be motivated. We said that go to one department, at least one person will be motivated. And let's take this story that, can you report? And you say you are contributing to the national program. Okay? So this is how we can go ahead, we overcome the under-repeating, because we target the nursing. They are there all the time. So this is how we go for it. So if you look at the PJ infrastructure, how many clinical departments, how many manpower are there? So we have a satellite center in Shamgur, Faridkot, so it is expanded. So that way, even if you look at UT, we had 78 sub-centers there. So this is how we connected, and definitely, those disease, Alzheimer's, or the way the caregivers is there. I was taking a lecture of retired people from CSR. They are actually looking at, all this medicine because they have a chronic disease. So we have to target that. We come up with a guideline called patient safety guidelines. We call 350 patients in Naipur auditorium. Let's interact. We connected to the student, So this is how, because if you tell the student, class 11, 12, they have a grandparents, they have parents. So they can motivate that, then there is a system. So this is how we look at the patient-centric reporting is there. But that when you go to hospital, nobody has the time. Resident work for 16 hours, 15 hours. So we devise the instrument, you press the button, you get a report. So this is an Android application, so you get all this. We wanted to launch as PGA model. So this is how these people have worked. But as you can see that, problem is huge. We can only see tip of iceberg. If I report 500 ADR from PGI, we get 10,000 patients in a day. Okay? And all this, that means still maybe 10 to 20%. We are not able to report the 100%. So then you can see that all this satellite center you're expanding. So definitely we have an achievement. So since they started the program, every year we are the highest reporter from PGI, #1. So we are going to have a meeting also with this forum. I just wanted to tell you, I happen to be chairman of IUFOR for next 4 years. So we are going to have several, seminar. So all of you can, attend the seminar. We're going to have the meeting in Dakar, Africa, on natural product. So as you can say that, should we report that Ayush product? We have a harbor vigilance. Ministry of Ayush has a program. So all this drug therapy or food or anything you come across, you please report. We need to have a database. So this is my group. But ultimately, I just wanted to tell you that we want to have a self-sufficient decision. If you take a drug from the market, it should be based on Indian population. I'll just give you one simple example. Pioglitazone was withdrawn because of 3 cases reported from Medanta. It was a very, very active decision. But later when you look at PBPI, we didn't have any case. Again, it was reintroduced because there is no concept of global ban. That any restriction or any modification is based on Indian population. Another example, phenylpropylamide. Question was raised in the parliament, why this drug is continuing in India? Because US is banning. Then they say, is it Indian people are guinea pig? But when you look at the data, they use a very high dose for treatment of obesity. We use for paracetamol, caffeine, or phenylpropylamide. We didn't have any case. So moral of the story is we wanted to implement pharmacovigilance system across India in order to minimize ADR, in order to improve that patient care system, and so that we can prevent or you can minimize. How can you prevent? When India introduced Bidaculin, it was an extended phase 2 program. But there are two concerns of Bidaculin. One is hepatotoxicity, then it's cardiac arrhythmia. Now, how it can have cardiac arrhythmia? Because of, in summer, you're prone to have, because of, hyperkalemia or hypokalemia. So if you have a hyperhydration, you can minimize the problem. So these all factors you have to see when you critically analyze any of the case, and you can manage the patient. Can I prevent? Can I minimize? And that's how you have to do it. So that is why the clinical input is very important, because we need to motivate the clinician so that they report, they understand that we are contributing to the national program, and that's how we can go ahead. Thank you very much. Thank you, Jai Hind.
We can have one or two questions from the audience.
Any questions? I'll be happy to answer.
Sir,
yeah, please.
It's always very listening to you. So like this is normal conversation है. आपने लिखा patient and families के last point was he asked your doctor why you are taking this medication. Even this is one of the preventive steps where we get to avoid the pharmacological. हम सब pharmacist हैं, हमें knowledge रहती है, and in fact knowledge रहती है. That's why we ask the doctors कि हमें ज़्यादा knowledge है या जो मर्जी करें. एक लेमन है, अब मेरा बेटा है, वो लेमन है, because he doesn't know any he's at the age of. मैं उसको बोलती हूँ बेटा please be alert and ask your. Sometimes when I do not join him, you go to the doctor. मैं उसे कहूँगी कि बेटा पूछो, right? उसको फिर डॉक्टर नो डाउट यहाँ पे दोनों की ड्यूटी आती है. डॉक्टर उनको ये बोल देते हैं यहाँ पे आपको उनका क्या लगता है ड्यू रिस्पेक्ट टू ऑल द फिजिशियंस एंड डॉक्टर्स, वो उनको कहते हैं एक दिन उसमें मत पड़ा करो, हो जाएगा. आप लोगों फार्मासिस्ट हो या आपकी मम्मा फार्मासिस्ट हैं, आपकी मम्मा ज़्यादा सोच रही हैं, इन चीज़ों में मत पड़ा करो, डेली खाली है या पूछो या ना पूछो. सो सर इस विजन को नो डाउट आम पब्लिक को भी हमें चेंज करने की जरूरत है, लेकिन डॉक्टर्स को भी उनको कैसे कहना है कि लाइक इट इज आवर कंसर्न. मैं एक
एग्जांपल लेता हूँ. पहले कोई भी डॉक्टर से बात करते हैं तो ऐसे बोलता है कि फ्रॉम माय एक्सपीरियंस दिस इज द बेस्ट ड्रग. So then today you say that from your experience it will not be counted. You have to see the level of evidence. So that mindset is also changing. So you refer it to guideline, you refer to Indian data, So doctor भी आजकल नहीं बोलते, जो who are knowledgeable doctors, So that is also been changing. You have to tell. And second point is we need to also understand, that you go to clinics, doctors do not speak to nurses, doctors do not speak to pharmacists. That mindset also need to be changed. That we are the team. We have to work as a team. So then only it is successful. That is also changing. So we have to change, and change will come over a period of time. It takes time. So one of these, doctor has come. He's a, son of a faculty member. So he wanted to learn pharmacovigilance. Then I told Benjamin, just teach him. Then somehow he came to know that Benjamin is in M-Pharm. And he stopped coming. So I called his father that he's not coming for last 3 days. I called him also. The mindset was that since he is M-Pharm, I am an MD student, I'm not going to interact with them. That mindset will not work. So that is why when you go to any of the hospital, we approach the team. A physiotherapist, a radiologist, those are the paramedical importance. This is very important, that how you motivate. If you give an award, appreciation, you're doing good. In OPD, I used to take an evening class. Nothing else, just motivational. You're doing a good work, serving the people. That actually fulfills the criteria. And that is what we have to think. Don't go for a superiority. All of us are equal. We have to work. While you're working for a patient care. That's what we have to think of. Thank you.
Recently, my son, he's in hostel, right? I couldn't join. He got some allergy after taking mifenyric acid, a very common painkiller. He got rashes all over the body.
Yeah.
So I said, just go to your, in the university. And the doctor said, your mama is making over and nothing to worry. So in that case, I was thinking I should report the ADR. I was
Definitely. We have a system, anybody can report. We have a toll-free number, anybody can report. And you know that we do not have a concept of individualized therapy right now, only for cancer chemotherapy. You can go for individualized. But you can say, if you report a case report, you save a lot of lives. Okay, thank you.
Politely convincing the healthcare professionals, and by using our inner powers, I am sure that it will gradually bring the change, and change is the necessity of the time.
So one humble submission I would also like to express. The patient load on a doctor in India is also a fact that they are not able to communicate that much. That is also a factor. We need to work upon that also, because the number of patients in the waiting are so much that they don't have that kind of thing to explain everything to a single patient. That is also a thing which I have personally observed. Yeah.
Yeah. I also just want to give one more message to each and everyone. The DCGI has also issued a circular that in the time to come, every retail pharmacy shop and wholesale dealers will also have the QR code of our ADRMS displayed at prominent places. And in many states of the country, like in Pondicherry, Odisha, Chhattisgarh, Goa, these steps are also being taken, how the public can be made aware of or reporting of adverse to the pharmacovigilance program of India. And there are faculty members sitting here like Professor Ziaur Rahman, the persons who are very active, Professor Vikas Bedi and many more faculty members who are convincing their staff how reporting can be enhanced, and they have also introduced the toll-free helpline number of Pharmacovigilance Program of India 1800-180-3024 in the hospital OPD cards. And not only this, we are also getting the suggestions from persons like Professor Vikas Bedi that the toll-free helpline number should also be introduced in the IPD files of the patients, so that data can be collected from there also. And I think AIMS Guwahati has taken proactive steps for introduction of this book in the patients' IPD files in their hospital. And I am sure that others will also take such initiatives so that the reporting is increased. Forget about whether the causality is done or not. Let it be reported first. Thank you, and I thank Professor Vikas Bedi for this, for sharing your clinical experience and how you are managing the AMC, and your RTC is one of the most active RTCs in PhD. Thank you very much.
Thank you, sir. So now I request our chairperson to please introduce our next speaker for the session.
So we have our next speaker, Dr. Shivani Juneja. Dr. Shivani Juneja has done her MBBS from Government Medical College at Amritsar, and she has done MD Pharmacology with gold medal, and she has been very active as the past coordinator of ADR Monitoring Center of Pharmacovigilance Program of India at Fortis Mohali, and she has the national and international publications to her credit. So with this brief background of Professor Madam Shivani Juneja, I invite her to share her experience how the medication errors can be tackled through the pharmacovigilance. Over to you, Mr. Thank you.
Thank you very much, sir, and good morning everyone present here. And I would like to thank Dr. Jayaprakash for giving me this opportunity and having this stage for me today. So I was just listening to Dr. Mehdi, sir, and there are a lot of things to relate, from now I am coming with a corporate experience. I mean, this is what everyone on national front are trying. So when I would just share with you to begin with, when I joined Fortis Healthcare, so I am the pioneer to start the PVPI association for Fortis Healthcare. So that was something I was carrying the legacy from doing guessership in Maulana Azad Medical College, Delhi. 3 years I was into the PV activities, and somehow after my association with various places, I thought I should introduce it in the corporate hospital too, because this is ultimately required for the patient safety for all of us. So that's how I began my journey as a coordinator of Fortis Hospital Mohali, AMC coordinator of Fortis Hospital Mohali. So first and foremost thing which came to me, when I joined as a clinical pharmacologist in that hospital, the clinicians coming to me and whenever, humbly asking them few things, why do you think this is not reported and we should come up with this? So these are the challenges which are everywhere. So we have, we look at it at different eyes and different establishments. So the first thing I was told that, why would I listen to a pharmacologist? Who are you to tell me this all? So I thought this is not the right time to answer. So I kept quiet. Then somehow COVID came in and we had a lot of challenges at a corporate hospital with such a tertiary big hospital and a lot of COVID cases coming to us. So, developing a lot of treatment protocols and a lot of challenges, and we started medication based, tried our best to deal with the COVID situation. So after 2 or 3 years, so I can happily say that the clinicians, my own colleagues and friends would call me, do you think this is the right way to take this treatment ahead? So then, after 3 years, I would say that was my worth not to be told. That was, I was doing for it, for the patients, for whatever I have learned in my life. I was doing it with all my team. I had a good team of clinical pharmacists, with the nurses, and everyone has been cooperating so well. So that is why we came up. So it took a little time to recognize what is required. So even till date, I am associated with various hospitals and serving as a consultant and giving all these services and trying to educate the nurses, pharmacists and everyone about the importance of pharmacovigilance. And plus with that, I am trying to touch upon the part of self-medication which is in the patients. So patient awareness is also very important because with the over-the-counter drugs availability, freely availability in our subset, here. So we have a big challenge. Nobody knows what to take, but still we are taking. And COVID has given us lieu of taking a lot of drugs by our own, and we have a habit of sharing with each other. This is what I was cured with. इससे मैं ठीक हुआ तो तुम भी ले लो. ये हमारी बच गई है, इसको waste क्यों करें? Now medicine has also become like fruits and vegetables which we don't want to waste. No, so this is something we need to work on when we talk about the patients. So a lot of things, self-medication need to be taught about, and then the adverse effects associated with the drugs. So I'll not get away from the topic today. I'm going to talk about is the tackling medication errors with pharmacovigilance. So as Dr. Sashi Bhushan has already started with this presentation saying that 1/3 of ADRs are due to medication errors. So I'm coming to that topic of taking it into detail. So most of them are preventable. How? I'll just talk about it. So medication errors, right? I'll not go into the little details, I mean, in the interest of time. So I believe most of you know that medication errors are very important to be recognized. It is not at the level of doctor itself. Mainly the nurses who are closely working with the patients, because what patients tell the nurses, they do not tell the doctors, because they are with the patient for a good time. So they need to be trained for this thing. They should be knowing, because this is one area where nurses coming in the hospitals are usually not aware of. So medication is a big challenge, though in good institutions where they have academic programs like in PGI where they are kind of given the trainings and education on timely basis. But in corporate and small hospitals, this is a an area which lags behind. So pharmacovigilance is helping in recognizing medication errors also. So this is something which we don't know, and this is something which, how do we get to know? Till we are reading the individual case safety reports properly. Before that, we need to fill it properly, because still we are not putting the right details into it. We are not able to recognize whether it is actually because of the drug or because of any factor which is associated with the drug, which may be in the form of medication error. So medication error is a preventable event. So this is, you can just read the last line, when it is in the control of healthcare professional, patient or consumer. So we have medication errors of different types. It begins from the prescription, administration, transcription, monitoring to dispensing. So we have various subcategories under these major categories: prescription, administration, transcription, monitoring errors. So how do we get to know whether this is a harm? You can just see there's a retrospectroscope. We have to look at the incident reports which are given and find out whether it is actually because of the drug per se or because of any place where, just like somebody has prescribed an inappropriate dose, it could be inappropriate duration, or the administration is not right. It could be not the right route of administration or the way of administration. So, and in fact sometimes the monitoring is lacking, because there are a lot of drugs which require monitoring. So till we know what is to be monitored, how do we get to know? And we report it as a ADR. So this is how we need to look into it. It is not that it should not be reported. What I mean to say here is, reporting ADR is beneficial in other way also. I mean, helping us identify the medication error. So it should be robustly reported. So this, in fact, I'll go forward and tell you more about it. So medication errors reported as ADR, this is real time what I have seen. Sometimes wrong AST of the drug is given. I'm just giving you a few examples. It could be inappropriate storage of the drug. Sometimes we do not read the labels. Sometimes the drug is for single use only. And the dose, when given, we think it is just left out and we can use it for the next time also. So, or sometimes it is not reconstituted properly according to the given instructions. So, these are the micro things which I am talking about. Some of you who may be intending to work in a hospital. So, with the team of clinical pharmacists, I think that's a boon to a hospital who can train the nurses ahead, because everyone cannot be present everywhere. So, pharmacists can be a very good resource in teaching the nurses about all these aspects, and which can prevent medication errors ahead. So then I've already talked about the inappropriate dose or duration of the drug, or it could be wrong route of administration. These are some of the examples which I have myself seen. I mean, we have reviewed the reports. We used to encourage to report. Whatever you find, you report. Just like Sir has already said that we need to kind of report each and everything, maybe in the hemovigilance, herbivigilance or whatever, because patients are at times not giving the right history or drug history. What are they taking? So when they are sometimes landing up in emergency, we do not have this, what we call it as medication reconciliation. So when the patient is admitted, at times some things are left out. It could be some other drugs the patient are taking, and there are a lot of things when we look into the prescription, just like therapeutic duplication, which usually happens when we lack the history of what of the medication history when the patient has presented to the hospital. Sometimes the attendants are not aware, sometimes the patient is not in a state to tell what he is actually taking. So that may result into ADRs. Therapeutic duplication can also result in, because the dose may exceed what we are intending to give now and what the patient is already taking. So how do we detect the medication errors in practice? This is what I was talking. So we have incident report review. So in most of the hospitals, the quality departments are getting the incident report. Sometimes, the healthcare workers don't know where to report the things. So when one hospital is actively engaged in pharmacovigilance activities, they can very well take that report and find out this is an ADR and we need to report it. So, some people find it very difficult. Healthcare workers find it difficult to fill that ADR form because they feel it is, a big activity. So there were few practices that we started as we introduced a slip, just like a yellow card has said in some countries. So we made use one slip and gave it to all the counters in IPD to the nurses and asked them to just write the name of the drug and the reaction they have seen and the patient UHID, so that we can get back and take the details of the ADR if it has happened and report it further. So this is how we make use of incident report review. Then we have patient charts when the clinical pharmacists are reviewing the charts every day, on their daily rounds. So this is another way of taking the ADRs. Direct observation is when you are going for the rounds. And intervention, as I already said, pharmacists they can intervene in lot of ways for medication safety, patient safety, and pharmacovigilance is one aspect of it. ADR tools, sir has already discussed. The AMC centers have been given an access to report it, and as I already said, that medication errors are preventable ADRs. So sir gave me that opportunity to publish it in the last IPC the newsletter, which comes, after I think 3 months. 3 months. So I got that opportunity to publish it there also regarding the preventable ADRs associated with the medication errors. So this is WHO is also talking about the same thing, and they're trying to educate the masses about these preventable ADRs. So these are all related with the medication errors. If you can see that the factors related to the professional, from the industry and everything, all the categories have been defined, and this is being done by the pharmacovigilance centers in the world. So we are also trying to get into, that genre of reporting from the pharmacovigilance center, the hospitals which are not able to report the medication errors with the help of ADR reports. So how are we doing it? We are making use of the individual case safety report, which I have already mentioned. So information on the IACR, sir has already briefed what all information we have there. So just to mention, there are few publications already done where medication errors are being detected in the pharmacovigilance center. So it's a double benefit. That's what I wanted to talk about. It's a double benefit. Reporting is very important. It is going to help us in both the ways. You're recognizing the ADRs and recognizing the medication errors. So these are all the details that we see. And this is another publication from New Zealand where they have used the pharmacovigilance database to detect the medication errors. Similarly from Africa, and if you see the causes of ADRs, if you see the most common are the inappropriate schedule of product administration, incorrect dose administration, and similar, as I already said, related to the medication administration processes. So this is what we need for ADRs can be prevented by giving proper. Why are they happening? Because of the inadequate patient instructions. Sir has already said. There are few things which are already been covered. We need to interact with the patient. That is very, very important, especially in the OPDs. I know with lot of patient load in the OPDs, time is less. But one person in the form of nurse or pharmacist can always be trained. They can explain the prescription and tell the patient, if you get these kind of untoward effect, you should report it. So reporting is not only through the healthcare workers, there is a separate form for the patients also developed by IPC, which is there on the website. We can make use of that, give it to the patient, tell them that you can report the ADR here also. So this is how, in future, the way we are going ahead in a very good way in respect of reporting, we can use this channel which are already provided. This is all about awareness, education, telling the people how to go about it. It's not about that things are not available, things are there, but we just need to be, aware about how to take them ahead. So understanding everything, this all I have talked about. So more than 2/3 of ADRs are probably or definitely preventable, which we have already talked about. So this is an important resource. Just to wrap up, pharmacovigilance, I already said, is crucial in reducing the risk associated with the medication errors, and this ensures patient safety, and I believe this is a key role of all the healthcares who are involved with the patients, and we can, utilize the ADR reporting in hospitals to identify the medication errors. That's the crux of what I need to talk today. And since the young generation and the people who are already in the hospitals can, give this message to the people and to the healthcare workers humbly, taking your own time, because the results will not come today, but yes, in the coming few years you will see the change. The change will start from us, and we should know how to take this change ahead. So with this all, I would like to thank you all, and especially sir.
Can we have just one or two questions from participants? So if there is no question from the participants, so it is time to thank Dr. Shivani Juneja for giving a very good comprehensive coverage of how to tackle the medication errors with pharmacovigilance. Thank you so much.
Thank you so much. I would like to request the chairperson to please honor Dr. Juneja. I would request Professor Kanwaljit Chopra to please join. So now I request the chairperson to please introduce our last speaker of the session.
As you go on pharmacovigilance and other systems, one of these, metro vigilance program of India. I just wanted to tell the student that we have very few people expertise of device. Today, if I ask how many people we have an expertise on preclinical toxicity study of devices, class A, B, C, D, especially C, you can count the number. I can count the number lab they are doing. They are just investigating. So we have a program, and program is launched in 2015. So I'm happy to introduce Dr. Naveen. And he is a scientific assistant. He is working for NDPL and very potential candidate for future prospect. So I look forward. Naveen, go ahead.
Thank you, sir. Thank you for the introduction. So without further ado, we'll start with the session. So I think we'll skip past this Indian Pharmacopoeia's introduction. I think the past session has clarified the role of Indian Pharmacopoeia and their contribution in pharmacovigilance program of India. And we do have an additional program, which is, as Dr. Vikas Miti has informed, it is Material Vigilance Program of India. So what is a medical device? So before going into the definition of the medical device, I would like to ask to the entire audience, how many of you are using a medical device right now? Just glucose monitor. Spectacles, yeah. Spectacles is a medical device. How many of you are using a contact lens to your daily purpose? It is a medical device, and there are numerous medical devices that is incorporated into the daily life of people in today's world. I think one of the most critical medical devices that women are using is sanitary pads, which is often underreported in India due to the taboo which is there. I think the person who are in a study and who are coming up in the world, so you have to report, come forward if there is any adverse event related to the sanitary pads or any menstrual devices that you are using. You can report. It is a medical device and it will help the entire population of India. Okay, and as a medical device, all the instruments, all the apparatus or hematological kits, pregnancy test kits, or any disinfectant that is used to clean the sterilize the medical device is considered as a medical device. And also the software products, the current AI or any software that is used to diagnose or to detect which in the medical device is also considered as a medical device. So this is a just comprehensive definition of the medical device. So you can have, for example, if I check diagnostic, prevention, monitoring, treatment and evaluation of disease, diagnostic, monitoring, treatment and evaluation of or compensation for an injury, investigation, replacement, modification or support of anatomy or of a physiological process, this wheelchair, this hand rest and assistive devices. So the persons like the smart cane and numerous, so hip implants and this hearing aid, all are medical devices. And we have this control of consumption, this condoms and copper T, all are medical devices, and providing information by means of in vivo examination of specimens derived from the human body. And so this is a comprehensive description of how the medical device is classified in India. We have 4 classes of medical devices, which from low risk to high risk. Low risk is class A, and low to moderate is class B, and moderate to high risk is class C, and high risk is class D. So low risk, which doesn't pierce your epidermis layer or dermal layer, it is outside, like surgical dressings or bandages or non-measurable, non-sterile devices are coming under this class C. And class B is low to moderate, basically your syringes, your sterile surgical gloves, masks, your PPE kits during your surgery procedures, and the hematology reagent kits all comes under the class B. And class C are moderate to high risk, which basically supports the patient, like this ventilators, patient support monitors and patient safety monitoring systems, and this bone fixation plates which are in the body for a small duration. During the fracture they'll fix this bone fixation plate, and after that they'll remove this. So these are all small replacements in the body, which is for 30 days or below 60 days. It is considered as class C. And the implantables, stents and this assisted device, cochlear implants, all considered as high risk class D device. And the definition of medical vigilance is that similar to medical device, pharmacovigilance, it deals with the drugs and this deals with the medical device. Any adverse events or incidents related to medical device is considered as a medical device adverse event, and it is studied and determined under the material vigilance. So the need for material vigilance, I think already it has been described by Dr. Vikas Mehdi, the incident related to the incubators in India, where babies were getting charred due to the faulty incubators regulator. And this incident prompted the Ministry of Health and Family Welfare to put forward this agenda in the material vigilance program of India. So it was started in the year of 2015 as the Sri Chitra Tirunelveli Institute of Medical Sciences as the National Coordination Center at the time. In 2018, IPC became the National Coordination Center. So since then, we have taken numerous measures to increase the awareness of this program. We have introduced various forms. In 2019, we have introduced the PPE kit form, which was especially a lot of faulty PPE kits was introduced into the market due to the demand of the PPE kits. So we have a separate form for that. And in 2020, IPC launched the IPC coordinated with various state programs and state governments. So they have launched various GOs which helped in the increasing of numbers of monitoring centers under MVPA. And in 2024 we launched the ADRMS. In August 2024 we launched the ADRMS, which is an indigenous software for India. And using this software you can report the adverse events related to medical device also. And this is the 4 pillars of IPC, 4 pillars of MVPA. So IPC is one of the 4 pillars, which is a National Coordination Center, and SCTMST is a resource person for this. They provide technical support and R&D support, and NHSRC is the National Health System Resource Center. They provide the support in assessing these district hospitals, NHM, and various other helpful things. And CDSCO, as obvious, it is a national regulatory authority. So any action that is to be taken through this material vigilance is done through CDSCO. So we are a scientific body. These three provide the scientific input to this national regulatory authority. They will take the action from there on. So this is our current presence. We have 636 medical device monitoring centers, which are basically hospitals. PGA is one of our prominent medical device adverse event reporting center, and we have 636 so far. So we are trying to increase our number. And these are all our regional training center. We have 9 regional training centers, and PGA Chandigarh is one of our regional training center. And these are all the various reporting modalities that we have. So one is medical device adverse event reporting form, which can be found in the NHSRC website and IPC website also. And we have this ADRMS, which is a software, and we have launched the PVPA mobile app, which is available in Google Play Store. And we have a toll-free number 1800-180-3024, which is available from Monday to Friday 9 to 5:30. And it is currently it has 10 languages, so you can report in regional language as well. And we do have launched the new form, which is IVD, in vitro diagnostic reporting form, which is available in IPC website. And this is the just brief overview of the software, which is a cloud-based software developed in collaboration with CDAC and IPC. And it streamlines the reporting of both medicines or drugs, vaccines, and medical devices. So this is a registration type. It's just like a social media. You can register as a social media. You can just type in Google and you can get this ADRMS IPC. It will be there. And this is the minimum requirement. So similar to similar to drug, we have for medical device. So we need an untoward event or an outcome. We need a suspected medical device or in vitro diagnostic kit, and we need an identified reporter and patient. If not, in some cases, we'll call it as near miss incident, where the patient is not involved. For example, if you are using a syringe and you are identifying an unknown particle or a contaminated particle in the syringe before it is introduced to the patient, then you call it as near miss incident. We'll report the incident and we'll report it as a non-serious incident because the patient is not involved. So these are all the various reportable adverse events. So which is device performance issues, labeling and packaging issues. Whenever if it is a sterile package and the package is missing the sterile label, you can report, or any instruction is missing or any instruction for use is missing in the label. For example, class A and class B devices, there won't be any IFU. A separate leaflet will not be there. So you can check the labeling of the package. If such information and content indications are missing, you can report this incident. And malfunctions leading to injury and potential injury, public health threats, poor quality issues. Poor quality issue is one of the major reportable event in India. So we are the largest manufacturer of class A and class B devices. So India is currently a $50 billion industry, $50 billion industry, and it is supposed to be by 2030 it will reach 50 billion, 50. So it has a tremendous growth in medical device industries, and currently we are the largest manufacturer of class A and class B, and we are importing class C and class D devices. So the high risk devices are imported mostly, and class A and the low risk devices are manufactured in India. So the most of them are encountering quality defects, so you can report poor quality issues. Off-label use, if it is a single-use device and you are using, or you are finding a healthcare professional using it multiple times, you can report this adverse event also. Near miss incident, as I said, if there is any near miss incident, and user error as well. So what happens when we receive an MDAE in IPC? So through various resources we are receiving like market authorization holders, which are basically manufacturers, importers and distributors, and healthcare professional, plus we have medical device monitoring centers and our associates and consumers. When we receive a report, we'll check for the quality, whether all the information is there or not. We call it as primary analysis. So once we have done this primary analysis, if the information is there, then we'll proceed for the secondary, where we'll ask the subject expert whether this particular event is associated with the medical device or not. If they suspect the association, then we'll proceed with the partners meeting, where various IPC, MVPA partners will join, CDSCO, NHSRC, SCT, MST, and various experts from PGI Chandigarh. Dr. Vikas Mehta is the chairman of this Partners Meeting Association, and we'll invite the manufacturer as well, the person whose medical device is suspected, for a clarification. So based on the conclusion of this meeting, we'll either give a recommendation to the CDSCO for further action, or if the information is less and we need more surveillance, so we'll send a safety alert to all the hospitals that is associated with MVPA as a safety alert, and we'll ask for more reports related to this particular adverse event. And this is the current status of the reports. So we have break the previous year reports. So currently we have crossed the 13,000 report marking. But if you can see, this is a severe underreporting. So 13,000 is like, I think in PGI Chandigarh itself, they'll be using it in a day. 13,000 medical devices, they'll be using it in a day. But the entire India is giving us only 13,000 reports. So we need more awareness and more reports to us. And then everyone is working towards that. And this is the action taken so far. So we have recommended 59 recommendations to CDSCO, and one product recall has been taken, and one joint investigation has been happened so far. And we have removed 2 counterfeit products from the market, and we have implemented 3 IFU changes through manufacturer, and we have issued 37 safety alerts so far. And this is the segregation of who reports the most. The healthcare professional is the one who is reporting the most. So we receive less reports from the manufacturer compared to the healthcare professional, and the patient is of the least. And we have device risk classification as well. So most of the adverse event is from the class A, which is of low risk, and we do have this cardiac stents and other issues will be reported. So these are all the various government orders that has been issued from various states to enhance the this meteorology system. Currently we have a public notice from NMC, National Medical Commission, insisting that all the medical colleges should have a committee, meteorology expert committee, and the committee documents and the SOPs related to the formation of this committee is available in IPC website. And these are all our various resource materials that we'll publish from time to time in IPC website and our social medias. This is a consumer form which is of a single page. So if you have any adverse event, you can report through this form, which is of single page, and it only requires the major information. And this is a pregnancy test kit adverse event form. So this resource material that we usually give to all the hospitals. So because false positive and false negative is also an adverse event, and it is a reportable adverse event. So this is for reuse of single-use device. Okay, that's it. Thank you. If there is any question you can ask. We'll just have a few questions and then we'll...
Just one question from the participants.
Anyone? Can you put it like? I just wanted to tell you, you referred to sanitary pads. How many of you know that there is a study is going on sanitary pads? So it has actually phthalate, and that has an impact in the long term. So the question was raised in the parliament, and then ICMR was asked to do the study. So one of the institute of ICMR in Ahmedabad, they are doing a study. It's ongoing on phthalate. So that is also very important, that what are the chemical exposure long term, it can affect. Any questions? You know, sometimes you do not realize that you are using devices. So I was taking a class for psychiatry yesterday, and I asked them that, do you use devices? All of them, they said, we don't use devices. Then I said, the cotton gauze you use is also a device. Cotton gauze, that is also a device. So you can just go to the hospital, you can make a list of devices, and till today we have more than 8,000 devices in India. And in US it is 12,000 devices. So now DTAB, Drug Technical Advisory Board, that's a highest body from regulator, they also put a recommendation that hospital can directly import the devices. So that means when you go to hospital, the clinician should know that how to check the quality of devices. And that means all the clinicians need to be oriented also. We don't have any exposure for software because all these devices have a software. We can just ask for a validity certificate. It will validate any regulatory acceptance. So there is also time has come as a clinician or as a stakeholders. You need to know that how to check for the devices for quality. Okay. So that means, as I say, it's a gray area. You need to learn. You need to study. So if I ask you that before you introduce to the clinics, what are the parameters you look for when you look at preclinical? You say pyrogenicity. You are entering into the body, can it cause fever? Hemocompatibility. So there are 12 cases you have to look for it. And all these products, when you use in clinics, it actually look for duration of use. Okay? So that means if you use for 3 months, you have to at least 3 times more, preclinical data need to be generated. And that's a principle you have to have. Then only you can say it is safe. Over to you.
Thank you, sir. Thank you so much. And thank you, Dr. Naveen, for the wonderful talk. I would now request our chairperson to please felicitate Dr. Naveen. So now we take a moment to express our gratitude towards our chairpersons. I would request Dr. Nilima Dhingra to please join, Dr. Shashi Bhushan to please join in felicitating our chairperson, Professor Vikas Mehdi. So now we would like to felicitate our co-chairperson, Dr. Jayaprakash. Thank you, sir. Thank you so much. Thank you, Dr. Shashi. Thank you, Dr. Nilima. So moving towards the next session, I would like to invite our chairperson for the session, Dr. Lekha Saha. Dr. Lekha, please grace the dais. Dr. Lekha Saha is a professor in the Department of Pharmacology at the closed PGI MER in Chandigarh. Her research covers a wide range of topics within pharmacology, including gastrointestinal, neuro, cardiovascular, and reproductive pharmacology. Dr. Saha is a respected member of several professional organizations, including Life Member of Indian Pharmacological Society, Life Member of Indian Medical Association, Member of National Academy of Medical Sciences, Fellow of International Science Academy, and the Life Member of Association of Physiology and Pharmacology of India. So we are extremely grateful for sparing your valuable time and joining us. I would now request to please introduce our first speaker for the session.
Hello, very good afternoon to all. I am Dr. Lekha from Pharmacology PGI. So I just want to introduce the first speaker. Dr. Anamika Gulati. She is an assistant professor in the Center for Studies in Science Policies, JNU New Delhi. At JNU, she teaches and supervises doctoral students, contributes to university governance as Associate Dean of Students and serves on several academic committees. Her research spans biomedical waste policy, clinical trials and drug development, scientific communication, traditional knowledge system and higher education in science. So I welcome Dr. Anamika to present her presentation.
Thank you, ma'am, for the nice words and the introduction. And good morning, colleagues. Let us just begin with a paradox that defines Indian pharmaceutical sector nowadays. I mean, we all should understand where we are standing in terms of APIs and KSMs because we all are in this sector for a very long time now. So India manufactures 20% of the world's generic medicine. And we are really the pharmacy of the world. We are known as providing the major pharmaceutical products to the world. But here is the uncomfortable truth that 70 to 80% of the APIs, that is the active pharmaceutical ingredients that go into these medicines, come from a single country, that is China. We are making the medicines, but we are not making it from the scratch. We are taking all the APIs and the KSMs from China. And even more critically, the raw materials and the key starting materials, I mean, which are critical in a few of the major products that we use on daily basis, that we need to make those APIs, they are also predominantly from China. And during the COVID, we all must have learned that when China briefly closed its doors, Indian patients really faced some challenges, that is the existential threats that we couldn't manufacture the drugs. It's not that we didn't have the ability to do that, but it was that we couldn't source the APIs during that time. But today I want to talk on how India is rewriting this story through what we call it as Atmanirbhar Bharat and the self-reliant India and Viksit Bharat. So the crisis, we'll first try to understand the vulnerability with these numbers because numbers really tell the truth rather than the text. So the numbers that matters is like 70 to 80% dependency of APIs from China, which is like goes beyond to 100% or beyond 90% in some cases like penicillin G, azithromycin or cephalosporins. The value cost is about 3.6 billion annually from China alone, not from the other countries where we still go for 20%, but from China alone it's 3.6 billion market. So 45 critical APIs where India has the import dependency on China. So this creates a paradox called the value volume paradox, where if we think that we are the major pharmacy, but we are on that 20% of the global APIs we are still producing, but that value is approximately 8%, just the 8%. Whereas China, in terms of volume, it is too less compared to India, but if we talk about the value, it is 40 to 45% of the market value, because the most critical thing, that is the upstream KSMs, are still everybody is getting from China. So where are the advantages of China? Why China is dominating in terms of APIs and KSMs is because of their massive economies of scale via state-backed industrial clusters they have, and then generous government subsidies they are getting that is causing lower effective costs, and then lower input cost of power, labor compared to other countries they have, and then vertical integrations of KSMs and superior infrastructure and logistics support scales with decades of technological maturity. So collectively, all these factors makes India challenge complex and multifaceted. So this we have discussed already, that even where APIs are manufactured, KSMs are primarily sourced from China, causing a problem for India, where we need a vertical integration. So So what is the government's response? How the government is responding to this challenge, especially post-COVID, what India has thought about it. They have launched a multi-pronged strategic response to this, where 3 pillars really act. First one is the financial incentive, the PLI scheme that government has tried to provide with a source funding of 6940 crores, especially for bulk drugs that has split up into 20% for fermented products, 10% for chemically synthesized products, and rest is performance linked, will be given in the later stages. So, which is mainly highlighting the production of APIs. 41 critical APIs is where India is targeting through this PLI scheme. That has resulted so far in 38 of them being domestically manufactured already, and 4570 crores have already been invested by the government and different agencies, providing a job to 25,000 or more people. So that's important, but there's still where it is crucial that PLIs work only if manufacturer can produce that competitively, and for that the pillar 2 comes up, that is the bulk drug parks. We must have heard that the purpose of bulk drug parks is to have a common facility where the waste treatment plants are common, uninterrupted power supplies is provided, effluent treatment plants are there, sustained streams and cooling systems are there, common testing laboratories have been into that cluster system, and integrated logistic networks is there. So we have 3 bulk parks which has been approved, and the work is going on to be probably started by 27 is the Gujarat, Andhra Pradesh and Himachal, which are providing a strong support for this API in-house manufacturing. And the centralization can reduce the per unit capital expenditure from 30 to 40%, which is a huge amount. And the third pillar to this is the research and innovation by establishment of various advanced academic and research institutions like we have in this university or other universities, where advanced research can be done to develop proprietary synthesis technologies, create apprenticeship models linking education with industry placement, that is important, and training workforce in advanced fine chemical production, backward integration into KSM, and then industry partnership enabling rapid commercialization. So that is providing a fiscal benefits and investment in research and education industry, having a tech transfer from academia to industry where a new product can be developed, especially in terms of KSM development. So supply chain resilience, competitiveness and sustainable growth is another important pillar where the government initiatives are taking place. But still the challenge is there is a bottleneck, which is the KSM. Consider that you decide to develop a atorvastatin, a very common anti-cholesterol drug or hypolipidemic drug. You build a plant, the PLI incentives you also get, you start the production, but the immediate raw material that you need to develop this, the KSM, again comes to China. So not just we can work towards development or focus on the development of APIs, we also need to upstream, to go for a backward integration so that we don't shift our focus from an upstream problem to a downstream one. So we should focus on that as well. So KSM manufacturing is little different, that's why the manufacturers are not focusing much on that, because it is more capital intensive, requires highly specialized fine chemical expertise. Fewer Indian companies have an expertise on that, so that's a problem, and requires proprietary process technologies, which leads to a backstage on this case. But we are working on that, and recently our Home Minister Amit Shah sir has stated that within the next 10 years India will not only become self-reliant on this, but we will also reach a stage where it exports APIs and KSM. So government is providing full support to that. But again, we need to work on both these factors parallelly, not just APIs, which is under PLI currently, but KSMs also. So the roadmap of, if we can see, Okay, so PLI we have discussed. So current achievements for PLI scheme is 50% import reduction we have already observed, with 115% of investment fulfillment. What was targeted has already been achieved, and it is more than what we thought about. And 38 APIs have already been domesticated, which is being developed in 35 plants currently, giving a high number of jobs as well. And not just a reduction in import, we have also reported a 455 crore of exports as well of API. This has been increasing. So this has been a great boost to our pharmaceutical industry and will be seen in the future months as well. So bulk drug parks, we have noted that Gujarat Bulk Drug Park, it is leveraging existing pharma ecosystems in Ahmedabad already. Andhra Pradesh FIFEP infrastructure, which is like it is taking care of all the foreign investments into the pharmaceutical sectors, FDIs and all those things, and Himachal Pradesh is promoting majorly the regional developments for utilization. So the advantages where bulk drug parks have is the common effluent treatments, testing laboratories, shared utilities, uninterrupted power, logistic optimization and regulatory coordinations. Where research and education infrastructure, we have already discussed that it has provided us, and the KSM bottleneck. Another problem is that competitive pricing that China is offering, but then our government can expand the PLI scheme not just to APIs but to KSMs as well. That can help us to mitigate this competitive pricing challenge. And then capacity scaling. 35 greenfield plants have already been sanctioned, but still we are a little behind from what we have targeted till to reach the number of 50. But government is working on that. And then technology gaps, and here where the academia can play a strong role in improving their technological know-how and transferring it to the new students so that this gap can be fulfilled. And for Vision 2035 is where we are targeting, and we have broken up into 3 major sections. That is the phase 1, which is from 25 to 27, where foundation and acceleration will take place, and which is already going on, and complete all the 3 bulk drug parks and domesticate 50 plus APIs. Currently we are at 30. So, and create 50,000 plus jobs. We are already at 25,000. And the second phase is 28 to 30, where we will be scaling and transitioning this and reducing our import from 60 to 70% reduction, and then establish 4 to 5 additional manufacturing clusters, and have more academic institutes, advanced academic institutes. And the third phase would be from 31 to 35, where a leadership and export orientation would be kept into mind, where from import to export we will be targeting. So let me conclude with the opportunity that global API market is projected to 37.11 billion by 2032 and growing by 12.33% annually, which is huge, and India currently captures 8% of this value. And by implementing this strategy, what we have discussed just now, we can capture 10 to 12%, this representing $700 million increment every year. But beyond the numbers, we have an opportunity to shift from a volume-based service or commodity provider to a value-based pharmaceutical power, and to transition from pharmacy of India to pharmaceutical architect of global health. That's what we target. Thank you.
Dr. Monica, please put on the lights. Any questions? Any questions from the audience? Yeah, please.
First of all, congratulations on your research and bringing data to us. So I wanted to ask, like you have said that we are dependent for 75% of the APIs from China. So there are some sections, like there are some classes which we are leading as a manufacturer. For example, antiretroviral drugs.
So my question is, are they dependent for API for those classes?
Yes.
China?
Yes. Majorly for all classes, antihypertensives, antihyperlipidemic, majorly the antibiotics, we all, in all these sectors, we are dependent on them. Statins is a very big sector where we are dependent on China.
Okay, and part B is like, which are the sectors we are focusing on manufacturing API from India, like just to
So I have a big list of them with me if I can name and if the time allows me. So we are focusing on losartan, valsartan, hydrocortisone. Sorry.
Non-infectious diseases.
Yes. So and neomycin, gentamicin, these are the few classes where we are focusing on so that we can take care of these, reduce our import sector.
It's on the basis of consumption?
Consumption, yes.
So, any other question? So, I think we'll stop over here. Now it's the time to felicitate our wonderful speaker, who's our own alumni, doing us so proud at Jawaharlal Nehru University. Thank you. It's a pleasure to host you. I would request Dr. Nilima Dhingra, Associate Professor, Pharmaceutical Chemistry, to please join for the felicitations.
It's my own university. I know, but you're a guest. I'm speaking for all of us. And it's proud to be facilitated from our seniors.
So, with immense pleasure, I would like to introduce our next speaker for the session, Dr. Rehan Khan. Dr. Rehan Khan is a leading nanomedicine researcher, currently serving as a Scientist D at the Institute of Nanoscience and Technology, INST, Mohali. His research group at INST focuses on the design and development of therapeutic nanoscale drug delivery system for the management of rheumatoid arthritis, ulcerative colitis, and neurological disorder. He also works extensively on nanoparticle-based synthetic lethal strategies for colorectal cancer, along with the preclinical safety assessment of nanoparticles in rodent models. Over to you, Dr.
Thank you for the introduction. Good morning, everyone. So today I am going to talk about this, the title of my presentation is Therapeutic Potential of Nanoformulation, Tiny Particles but Big Impact. So before going into the detail of my work, I would like to tell about my institute, the Institute of Nanoscience and Technology. It is the only institute in India which is working on the nanoscience and nanotechnology. And we have a faculty from different disciplines like physics, chemistry and biology, and all are working on the only one aspect, that is nanoscience and nanotechnology. So we have three different departments, chemical biology, energy and environmental, quantum device and quantum material and devices. So this is the chemical biology department. Here faculty are working in different disciplines like drug delivery and biomaterial for different biomedical applications such as cancer, inflammatory bowel disease, rheumatoid arthritis, peripheral nerve injury, spinal cord injury, neurodegenerative disorders, biosensing of disease biomarkers. So these are the area of my research. I am basically working on the development of nanomedicine or drug delivery system for the management of different diseases, cancer, experimental colitis, experimental rheumatoid arthritis, and neurological disorders. But in today's talk, I am going to cover the drug delivery system for the management of neurological disorder and rheumatoid arthritis. So my first study will be focused on LRP3 inflammasome targeting nanomicelles for preventing ischemia reperfusion-induced inflammatory injury. So before going into the detail of my study, first I would like to tell about the anatomy of the brain, how like blood circulate into the brain. As you can see here, like blood supply to the brain, with what part of the brain they are supplied by. See, this is the internal carotid artery. This is the internal carotid artery, and the other big artery is vertebro-basilar artery, and it's the circular obverus. These are the three main arteries which supply blood to the brain. And here you can see above the dotted line, this is the dashed line above the dotted line, this is the 70% of the brain part, and below the dotted line it is the 30% of the brain. As you can see here, brain is supplied by mainly two arteries, these two internal carotid artery and vertebro-basilar artery. Red color is the internal carotid artery. It supplies brain to the upper part, above the upper dash line, and this vertebro-basilar artery supplies brain to the lower part of the brain. So it means that 70% of the brain is like supplied circulation by this internal carotid artery, and internal carotid artery is very crucial for the brain functioning, normal brain functioning. And when we look at the model that we have used in the preclinical studies, that is a middle cerebral artery occlusion model, and when we block this external carotid artery, then what happens? It creates the stops the blood supply and causes the cerebral ischemia, any ischemic region into the brain. There's one clear message that blood in this particular artery goes towards the brain. So now I'll why I'm discussing this, I'll come to my next point. Why we need the drug delivery carrier system for the enhancement of drug solubility, increased viability, targeted therapy, controlled release, combined therapy, and reduced side effects and personalized medicine. We are focusing on the combined therapy and the targeted therapy. And the limitations of the currently available therapy, side effects, incomplete efficacy, drug interaction, delayed onset of action, non-targeted approach, and low tolerability of the drug. And most of the drugs are hydrophobic in nature, that's why they have the low solubility. And in this particular study, I have developed the nanomycel. So before going into the detail of my study, I would like to tell the basic of the nanomycel. Nanomycel, if you see the individual component of the nanomycel, it contains the hydrophilic head and the hydrophobic tail. As you can see here, this is the single moiety of the amphiphile. It is a hydrophilic group and a hydrophobic group, and this hydrodynamic, it is a very dynamic structure. When you put this particular amphiphile into the aqueous medium, they self-assemble and form the nanomycel. As you can see here, this is the nanomycel, self-assemble, and nanomycels are different types, micelles and reverse micelles, and people have developed different type of nanomycels depending upon their use, like spherical nanomycels and cylindrical micelles. And this is one very important factor which have to keep in mind before developing the nanomycel. That is critical micelle concentration, that is CMC. We have to calculate the CMC through the pyrene assay when we are synthesizing or developing the nanomycel in our lab. Then what is happening is we have to calculate the nanomycel CMC, the critical micelle concentration. Below this value, you can see here all the amphiphile is in the non-micellar form. When the value is above the critical micelle concentration, only then they will be able to form the micelle. So it is very crucial to determine the critical micelle concentration when we are developing the nanomycels. So now I'm coming to specifically my study, like analogous inflammasome targeting nanomycel for preventing ischemia reperfusion-induced inflammatory injury. So before going into detail, some background I want to get what was the aim of the study, how to selectively target and deliver nanomycel in ischemic region of brain. So there are four things we have to be kept in mind. That first, what should be the route of administration so that I can we have to reach to the maximum accretion in the maximum accumulation of our nanoformulation into the brain. So instead of choosing the conventional intravenous route, what we have thought of injecting our nanomycel through the common carotid artery. Why we have chosen that? I have shown in the earlier slide when we developed the middle cerebral artery occlusion model, the blood flows towards the direction of the brain, and then I search about this in the literature. I got only one Google patent filed by the Professor Vinod Labashekar. He is working in the USA, and they have shown that they have compared the injection through the common carotid artery and through the intravenous route, and there is more accumulation of nanoparticle into the brain as compared to 20 times more accumulation of nanoparticle into the brain as compared to the through the common carotid artery as compared to the intravenous route. So that is why this gives the foundation that our approach is right, and we have chosen this route of administration for the maximum accumulation of nanoformulation into the brain. And after the accumulation into the brain, the nanoformulation then is spread to the other body organs. Then next is how to cross the blood-brain barrier. The crossing the blood-brain barrier itself is a big challenge. So what happens in the case of cerebral ischemia or stroke? What happens? Blood-brain barrier is slightly compromised, and it overexpresses the expression of transferrin receptor, the transferrin TFR1. The TFR1 is overexpressed onto the endothelial cells of the blood-brain barrier, and these endothelial cells form the composed of this blood-brain barrier. So what we have done, we have conjugated our nanomycel with the transferrin ligand, so that our ligand can bind to the transferrin receptors which are present on the endothelial cells of the blood-brain barrier, and it can internalize and help to cross the blood-brain barrier of a nanoformulation. Then next is after going into the brain, after reaching into the brain, crossing the blood-brain barrier, how it will reach specifically at the ischemic region into the brain. Then what happens, I have got one reference that in the ischemic region, the pH is slightly acidic as compared to the normal adjacent tissue of the brain. So we have conjugated in our nanomycel a pH responsive polymer, that is polyoxazoline. When our nanomycel reaches to the slightly acidic medium, slightly acidic microenvironment of the ischemic region, it will disassemble and show the faster release. So, and the last one is NLRP3 inhibition, as we are focusing on NLRP3 inflammasome complex, and we have chosen the drug that is MCC950, which is very highly specific drug for the inhibition of NLRP3. So this is the NLRP3, and NLRP3 inflammasome pathway plays a crucial role in the development of ischemia reperfusion injury. This is the schematic representation of our development of the nanomycel. As you can see here, polyoxazoline is a pH responsive polymer, and this is we have used the PLGA. PLGA is a FDA approved polymer for the drug delivery purpose, and we have conjugated with the help of DCT-MAP reaction, and we got this conjugate. And then finally we have developed the balamide group at the end, so that our transferrin, which is act as a ligand. So we have separately treated this transferrin with the Trout's reagent to develop the sulfahydryl group. So that sulfahydryl group at this end can react with this end. So we finally got this conjugate, and then we convert this conjugate into the nanomycel, and we entrap our drug, this MCC950, into the nanomycel for the delivery purpose into the animal model. So this is the preliminary characterization of our nanomycel. First, we have developed we have performed the FTIR analysis, and all the characteristic peaks of the particular conjugate is present, and we have confirmed this with the help of FTIR and NMR. Our nano formulation has our conjugate has been successfully formed. Then we have converted our conjugate into the nanomycel, and we have performed the dynamic light scattering, beta potential, EFM and TM characterization. As you can see here, the dynamic hydrodynamic diameter is about, for the final nanoformulation, is about 100 nanometers, and the beta potential value is around plus 20, and the size of we can further confirm the size with the help of atomic force microscopy and transmission electron microscopy. And then we have performed that in vitro drug release. As you can see here, I have performed the in vitro drug release at 3 different pH, that is neutral pH and slightly acidic pH 6 and 6.5. And as you can see here, at slightly acidic pH 6 and 6.5, the release rate of the drug MCC950 is faster as compared to the at pH 7.5, which clearly shows that this is because of the presence of the polyoxazoline, which is a pH responsive polymer which is present in the nanomycel, and in at the slightly acidic pH, this nanomycel disassemble and shows the faster release of the drug. And we have performed the this XTT assay to check the safety of our nanocarrier only. Then we have performed the cellular and brain uptake of nanomycel. Then we have chosen the neuronal cell line, and we have performed the quantitative cellular uptake through the flow cytometry and qualitative cellular uptake through the fluorescence microscopy. And our data show that in a time-dependent manner, our nanomycel is cellular uptake is higher in a time-dependent manner, and fluorescence, as you can see here, is also increasing in a time-dependent manner up to 24 hours. And the very important thing is how we can assess the whether our nanomycel is reaching into the brain in the in vivo system. That is very important, because blood-brain barrier is normally functioning in the in vivo system. And then we have taken the two groups, sham and treatment. And in the treatment we have encapsulated the DIR dye, that is the IVIS sensitive dye, which can be detected into the IVIS and whole animal imaging system, and we found that our nanomycel is able to reach to the brain and accumulating at the ischemic region, as you can clearly see in this slide. Then what we have performed the nanomycel inhibit the oxygen glucose deprivation induced NLRP3 inflammasomes and tunnel assay. As you see here, the immunofluorescence for the NLRP3, immunofluorescence for the cleave cascade 3, and so what happens, like an NLRP3 inflammasome complex is composed of three different molecules, that is NLRP3, ASC, and cleave cascade 1. Cascade 1, all the three together form the NLRP3 inflammasome complex, and this complex, when activated, they activate the downstream mediator, that is IL-1 beta and interleukin 18. So this confirms that our nanomycel has the ability to inhibit the expression of NLRP3 and ASC. As you can see here, the Western blotting, the protein band is reduced as compared to the OGD group in our nanomycel treated group. And this expression of the cleave cascade will also reduced, and IL-1 beta also reduced, and IL-18 also reduced. So it shows that it has the potential to inhibit the NLRP3 inflammasome complex and its downstream mediator. And again, we have performed a study in collaboration with my collaborators, and they have developed a chick embryo model which mimics the ischemia reperfusion injury. And we have performed again we have taken the arteries of the chick embryo, and we have again performed the same biomarkers like NLRP3, ASP, just to confirm that again in a different model of ischemia reperfusion injury. And we got the similar result. As our nanomycel has the ability to inhibit the NLRP3 inflammasome complex and its downstream inflammatory mediators. And finally, then we have developed the middle cerebral artery occlusion rat model, and we have first have to occlude the internal carotid artery through the injection through the common carotid artery, and then we have injected our nanomycel into the common carotid artery through the root. And we have performed the similar biomarkers again, all the same biomarker, NLRP3, AST, cleave cascade 1, IL-1 beta and IL-18, and we got the similar result, and further confirms that through the in vivo study, our nanomycel, which is entrapped with the MCC 950 drug, has the ability to cross the blood-brain barrier and reaches the ischemic region and inhibit the NLRP3 inflammasome complex. It suppresses the inflammation. And the conclusion of this study is, despite various advancements in drug delivery technique, we still lag behind in addressing concerns like side effects and targeted delivery to the site. Transferring conjugated nanomycel delivered through the common carotid artery exhibited preferential accumulation in brain might be due to both conjugated transferrin as well as delivery through common carotid artery. Both the factors can play a role here in reaching and delivering our nanomycel into the brain ischemic region. The most important finding in these studies is that the pharmacological inhibition of NLRP3 in vitro, in ovo, and in vivo by MCC 950 reduces oxidative and inflammatory stress and injury in neuronal cells. A 3-day developed chick embryo right vitelline artery and ischemic stroke rat model. And this study is published in the ATS Nano. if I still have time, so I want to share my other study, caffeic acid modified nanomycel inhibit articular cartilage deterioration and reduce disease severity in experimental inflammatory arthritis. So rheumatoid arthritis is again is a chronic autoimmune disease which is very prevalent autoimmune disease. It's characterized by the pain in joint, and it's most prevalent autoimmune disease. There is no perfect cure available for the disease. Only clinicians or doctors, they give the medicine for the symptomatic relief. And degradation of bone due to destruction of articular cartilage is the hallmark of this disease, and inflammation of the joint and inflammation and thickening of the joint capsule. These are the different stages of the rheumatoid arthritis. As you can see here, this is the healthy joint, and it starts with the inflammation of the synovial membrane. This is synovitis. And then in the next stage, it is the pannus stage. It is the pannus formation. It is the extra outgrowth, and which is responsible for the nerve pain in the patient. And then it starts slowly degrading the bones and cartilage. And in the final stage, there is a bony ankylosing. Both the bones fuse together, and this is mainly responsible for the disability of the patient suffering from the rheumatoid arthritis. So rationale for the selection of caffeic acid and 9-aminoacridine. So we have chosen caffeic acid and 9-aminoacridine as a drug, and caffeic acid as a conjugate, which is also a active natural compound which is present in many plants, and it is reported to inhibit the NF-kappa B. So what we have tried, people are developing the carrier only. What is happening, the carrier most of the time is only has the neutral effect. It does not give any effect, it just acts as a carrier. So what we have tried to develop the therapeutic carrier. Here in our case, our carrier can also give the therapeutic effect in addition to the encapsulated drug into the nanocarrier. So what we have done, we have chosen the caffeic acid as the motive behind the conjugation of caffeic acid. Is the several reports claim that caffeic acid has significant anti-inflammatory potential against rheumatoid arthritis by inhibition of NF-kappa B, and we expected that nanomycels themselves could show a protective mechanism against RA. So, and the drug we have used is 9-aminoacridine. We incorporated an old FDA-approved 9-aminoacridine drug, which is reported to potentially anti-inflammatory effect by activating the NR4A1 molecule. This NR4A1, what happens when this 9-aminoacridine is responsible for the activation of NR4A1? What happens when NR4A1 activates? NR4A1 is responsible for the inhibition of inflammatory pathways like NF-kappa B and HIF-1 alpha, and then it suppresses the inflammation. So activated NR4A was reported to exert anti-inflammatory effects by the suppression of pro-inflammatory markers such as NF-kappa B and HIF-1 alpha. We expect that anti-inflammatory potential of 9-aminoacridine and caffeic acid with two different targets, that is NR4A1, the target of the 9-aminoacridine, and NF-kappa B, target of the caffeic acid, might show an enhanced therapeutic outcome. We have prepared 9-aminoacridine encapsulated 9-aminoacridine encapsulated nanomycel by the solvent evaporation method, and efficiently characterize them for the conjugation with for the CA and for their size, shape and stability. So this is the schematic representation how we have developed this conjugate. First we have reacted the methoxy PEG with the epsilon caprolactone by the ring opening polymerization reaction, and we got this product, and through the DCC DBAP reaction we have conjugated caffeic acid. At this end, as you can see here, caffeic acid is conjugated onto the final conjugate, and we have converted this conjugate into the nanomycel, and we have characterized this nanomycel conjugate with the help of FTIR, NMR and GPC. GPC we have determined the size, and the size, our size increment in the size is confirmed that our nanomycel has been, that particular conjugate has been formed. Then we have converted our this conjugate into the nanomycel and characterized with the help of DLS. As you can see here, this is the DLS, size of the DLS 160 nanometer without the drug, and with the drug it is 190 nanometer. And then further confirmed with the help of 10 AFM. And then we have performed the drug release at like a normal physiological pH, and it showed the controlled release, and we have performed the cell viability and critical micelle concentration, and the critical micelle concentration was calculated to be 2.5, which is very crucial for the development of the nanomycel. And then we have performed the in vivo study. We have established the collagen-induced arthritis model, and as you can see here in the CIA, this is collagen-induced arthritis. CIA group is the arthritis group. This is healthy, and this is the final formulation treated arthritis rat. As you can see here, there is a reduce in the erythema and edema, as compared to the arthritis group, and our the histological studies further show that our nanoformulation shows the protective effects against all the particular histological studies, and as a safranin or stunning, it shows the protective, it's restoring the cartilage. The safranin O is really responsible for the staining of the cartilage, which is similar to the healthy group. And then we have performed the toluidine blue staining, which further show the protoglycan content, which also indicates the presence of the cartilage. As you can see, here darker blue lining, which shows the cartilage. Cartilage is preserved, and it's almost absent in the case of arthritis group. Then we have performed the immunohistochemistry for the molecular marker of COL4A1, and we have found that the expression of this marker is reduced in the arthritis group, but in the treatment of our nanoformulation, this expression is present. Immunophosphates cells are present in this group, and our nanoformulation is shows some protective effect against the arthritis. And we have compared our nanoformulation with the standard drug, that is MTX. MTX already used in the clinical, and doctor prescribed this methotrexate to the patient, and we have compared our nanoformulation with the methotrexate, and we found the similar results. And comparable, our efficacy of our nanoformulation is comparable to the MTX. And then we have established the path, this particular path, a mechanism how our nanomycel is working. And that, as you see, we have already shown that nanomycel 9-aminoacridine is responsible for the activation of NR4A1. Then we found that NR4A1 is reduced drastically in this CIA group, but in the treatment with our nanoformulation, which has the 9-aminoacridine, it shows the immunophosphatic cell, means it is responsible for the activation of NR4A1. And then we have also assessed the NF-kappa and HIF-1-alpha, both the biomarkers were reduced, the inflammatory biomarkers reduced in our nanoformulation group. And we have further confirmed all these biomarkers with the help of Western blotting also. And then we have performed the vital organ safety study. And because we have to see whether our nanomycel has any adverse effects on the vital organs, and we found that our nanomycel did not alter the histoarchitecture of the vital organs. The conclusion of this study, the protective mechanism might be due to the simultaneous inhibition of NF-kappa B by 9-aminoacridine and caffeic acid, whereas the activation of NR4A1 by 9-aminoacridine leads to the suppression of HIF-1-alpha. This combined therapeutic effects of 9-aminoacridine and caffeic acid have enhanced the therapeutic efficacy of 9-aminoacridine nanomycel and markedly reduced the severity of inflammatory arthritis. Unlike existing drugs for pain management and with limited efficacy, 9-aminoacridine nanomycel exerted a disease-relevant activation of blockade that alleviated inflammation and exhibited marked therapeutic efficacy against rheumatoid arthritis. This paper has already been published in HS Nano from our group. So lastly, I would like to acknowledge my PhD student. This work was mainly performed by the Akshay, and I would like to thank funding agency and my institute, IPSCON Mohali. Thank you.
Any question from the audience? I request Dr. C.S. Gautam kindly felicitate our speaker, Dr. Rehan Khan. Sir, kindly join the dais. Next session we are going to start after 5 minutes. Please be seated. Of IPSCON 2025. It is my proud privilege to invite our chairperson for the session, Dr. C.S. Gautam. Dr. C.S. Gautam is a professor in Medical College. Before that, he was the professor in GMCH Sector 32. Academically, he is MSc, PhD, LLM in the area of neuropharmacology, national use of drug. He is expert in the area of neuropharmacology. I invite you, sir. Also, I would like to invite another chairperson, Dr. Amita Sarwal. She is the Associate Professor in Pharmaceutics, IPSCON, Punjab University. Also, I would like to invite another chairperson, Dr. Nilima Dhingra, Associate Professor, Pharmaceutical Chemistry Section, UIPS, Punjab University. For this session, we have first presenter Blesna Mary Arukaraj.
Our first speaker, Blesna Mary Arukaraj, is from Christian Medical College, Vellore, India, and she's going to present a talk on the title, The Combined Relaxant Effect of Terbutaline and Sildenafil on the Construction of Isolated Non-Pregnant Human Myomate. So, over to you.
Good afternoon, everyone. I am Dr. Blesna Mary Arukaraj, postgraduate resident from Christian Medical College, Vellore. I am going to present on my study titled The Combined Relaxant Effect of Terbutaline and Sildenafil on Contraction of Isolated Non-Pregnant Human Myometrium. Introduction. Preterm birth, which is a leading contributor to major neonatal mortality and many maternal side effects and complications, which remains a major challenge and significant health concern in obstetric practices. Although there are many classes of pharmacological drugs which possess smooth muscle relaxant effects, no new tocolytic drug has gained broader clinical acceptance in recent decades. Though many drugs like calcium channel blockers, magnesium sulfate, nitric oxide donors, oxytocin receptor antagonists are available as tocolytic, the overall efficacy and adverse effect profiles of these drugs remain suboptimal. Our interventional drugs are terbutaline and sildenafil, terbutaline being a beta-adrenergic receptor agonist, which is a potent inhibitor of uterine contractions. Due to numerous maternal and fetal side effects, this beta-mimetic drug is not being widely used nowadays. Sildenafil, which is, as we all know, which is a selective inhibitor of phosphodiesterase 5, there has been preclinical study showing the relaxant effect of sildenafil in the human non-pregnant myometrium. A study has been done in our department also. There is limited clinical knowledge on use in pregnancy. Rationale of our study is like previous studies have shown that combined administration of sildenafil along with terbutaline in low dose combination had significant uterine relaxant effect in isolated rat myometrium. So further study in human myometrium may determine the synergistic effect which may be unique for human uterus. This may facilitate reducing the dosage of either one or both the drugs, thereby reducing maternal and fetal side effects while maintaining the drug's efficacy. Objective of our study is to compare the relaxant effect of full dose terbutaline with a combination of low dose terbutaline and low dose sildenafil on the contractility of non-pregnant human myometrium. Inclusion criteria:
Females aged between 20 and 50 years were included. Females who are undergoing elective hysterectomy for benign uterine pathologies like fibroids, polyps, prolapse and abnormal uterine bleeding were included. Exclusion criteria: patients undergoing hysterectomy for malignant uterine conditions were not included and postmenopausal women were not included. Methodology of our study: after receiving the institutional review board approval, the patients undergoing elective hysterectomy were recruited from the Department of Obstetrics and Gynecology, CMC Vellore, after receiving written informed consent from the patients. Uterine samples were received from the gynecology theatre in ice cold modified Krebs solution and transported to the postgraduate pharmacology lab within 30 minutes. The myometrial strips were prepared from normal looking tissue and mounted in the organ bath under optimal condition and connected to a data acquisition system. Tissues which had spontaneous contractions were considered viable and were subjected to further experiment. KCl 80 millimolar was used to induce contraction in the tissue, and our interventional doses were full dose terbutaline was taken as 10 micromole, half dose 5 micromolar, sildenafil full dose 30 micromolar and sildenafil half dose as 15 micromolar. The doses were taken in accordance with previous studies and the DRC done. The methodology: after mounting the tissue, 2 hours of resting time was given to the tissue, and KCl 80 micromolar was given a contact time of 2 minutes initially, which served as a control arm. Terbutaline and sildenafil were given consecutively in low dose, high dose sildenafil, low dose sildenafil, and the cumulative doses, half dose of terbutaline and half dose of sildenafil was also given. Each drug contact period of each drugs were 10 minutes, and the KCl contact period post drug was 2 minutes, and the recordings were noted. Adequate wash and rest was given to the tissue in between each set. Finally, we have compared the effect of the full dose terbutaline and the combined effect of terbutaline and sildenafil as reduced doses. This is our organ bath setup, which is connected to a forced transducer, and this is our data acquisition system connected to a software where we get the graphical traces of the myometrial responses. The height in grams and area under the contractile curve in grams per second were calculated using our software version 4.5.2, and these images depict the KCl contraction, and the tissue was washed after 2 minutes of KCl contact and was given adequate resting time. Terbutaline 10 micromolar was given, and after 10 minutes of contact with our interventional drug, again KCl was given along, and the height and AUCC were measured. Similarly to the combined doses also. Coming to our result, the height and the mean height and AUCC of full dose terbutaline compared with the KCl, the control arm, the full dose terbutaline showed both in terms of height and AUCC, both showed statistically significant reduction. And if we look into the low dose combination of terbutaline and sildenafil along with the respective KCl control arm, it also showed a statistically significant reduction in height and AUCC. All statistical analysis was performed using SPSS version 21, and Wilcoxon sign rank test was done. Here we actually plotted a box plot showing terbutaline full dose, percentage inhibition of terbutaline full dose, and percentage inhibition of the cumulative drug doses of AUCC and the height, which was the reduction in the upward shift in the median, and in both the drug arm were comparable, showing that the cumulative effect of the drug is also comparable with the full dose of terbutaline. Discussion. in accordance with the observation reported by T. Barna et al. In isolated rat myometrium, combination drugs, the terbutaline and sildenafil, produced a relaxant effect comparable to that achieved with the full dose terbutaline in isolated non-pregnant human myometrial tissue. Thus, combining a reduced dose of terbutaline with another agent which acts through different receptor pathway may provide adequate relaxation of the uterine tissue while minimizing adverse events associated with higher doses. Conclusions. Thus, low-dose terbutaline with low-dose sildenafil relaxes human myometrium as effectively as full-dose terbutaline. Reduced low-dose combination may improve tolerability while maintaining effectiveness, making them a promising option to use in preterm labor. This also highlights to show how repurposing a drug can extend existing drugs to new therapeutic uses. And also in modern healthcare, drug repurposing offers a faster, cost-effective way to develop treatments and meet unmet clinical needs. Further clinical trials are needed to prove our findings. I would like to acknowledge the Institutional Review Board, the Fluid Research Grant, Christian Medical College Vellore, patient participants who participated in the study, all the gynae surgeons, postgraduate residents from obstetrics and gynecology, CMC Vellore, all the faculty, staff and friends from our department, especially my guide and co-guide. I would like to extend my hearty thanks to both of them, and the Indian Pharmacological Society and IPSCON organizers for giving me this valuable opportunity. Thank you.
Thank you so much. So the session is open for any questions that we might have from the audience. Any questions?
May I ask?
Yeah.
Your concept seems to be quite a good one. In fact, I do government of pharmacology at Government Medical College, Chandigarh. I got a call from my obstetrician and gynecology headquarters. She said a lady is admitted and she says, I only wish to deliver when my husband is around for the garden. And with the stress, she also developed the asthma. And that time, now we use this drug which was acting to the beta-2 agonist and could serve the lady very well, because the day his husband ended, she delivered the child and the bronchial asthma was also taken care of. Now, this is the contention. That means beta-2 agonist has a very powerful role on the biometry. That is the reason for the vaccine. I would like to know from you what basis sildenafil, which is acting for the nitric oxide. Because if I tell you acetylcholine releases the second neurotransmitter, the nitric oxide only. And this can lead to the, bronchoconstriction.
Yes, sir.
That means what type of muscarinic receptors do you intend to see into the myometry? What type of muscarinic receptors? And having the two different basics, do you think you would have the synergistic effect?
Yes, sir.
That's my question also. No question I would like to ask. That you were saying that you are reducing the drug load. I'm a pharmacologist and pharmaceutical person. But then you are replacing 5 mg of the drug with 15 mg of sildenafil. So how do you justify that?
Ma'am, actually, we have tried with different doses also, and it has shown the relaxant effect. And that's why even while reducing the dose of sildenafil along with the low dose terbutaline, we are showing that low dose sildenafil also enhances the effect of terbutaline in terms of cumulative relaxation.
My question is that already 10 mg was the established dose.
Yes.
So you're trying to reduce the dose.
Yes.
And you are replacing 5 mg with 15 mg of another drug.
Yes, ma'am.
So you're increasing the drug load.
No, ma'am. Our hypothesis is to reduce the dosage. Like terbutaline is a known uterine relaxant, and it is not being used nowadays to show due to the hypotension, hyperglycemia, etc. Like sildenafil, if we add another add-on drug with terbutaline, it might compensate with the side adverse events of terbutalinazole and act as a drug.
My dear, let me now tell you, these days research is coming out with a fashionable term discussed by the fashionable people in a fashionable society.
Yes, sir.
Are you making a different type of combination? Because as a clinician I have seen beta-2 agonist is one of the best drugs yet to find any adverse effect in the patient given. Now the question is, this we all understand.
Yes.
Making a rational combination is the sighted idiot. Pharmacologists are silent on this. I don't agree with this thing. Either you convince me or get convinced.
Thank you so much. It was a wonderful conversation. Thank you. Now I would like to felicitate you. Please come up for stage.
I request the chairperson kindly felicitate our first presenter Blessenda Mary.
But I would suggest to all youngsters that at least she has the courage to express something, which in fact we hardly see among the youngsters. We are
Thank you, sir. Thank you, ma'am. Next presenter we have Dhyaneshwaram Sukumaran.
Second speaker is also Dhyaneshwaram Sukumaran, Christian Medical College, Vellore, India. The title is Protective Effect of Epsilon SP1-1005 on mucositis in rat, methotrexate-induced intestinal regulation of AKT/GSK3B signal. Please, I start.
Good afternoon, everyone. I am Dhyaneshwaran Sukumaran from Department of Biochemistry, Christian Medical College, Vellore. I am here to present my study on protective effect of epsilon SPI-1005 on methotrexate induced intestinal mucositis in rat, focusing on AKT and GSK3 beta signaling. So, up to 40 to 100% of patients who undergo chemotherapy develop gastrointestinal mucositis. The symptoms include diarrhea, vomiting, abdominal pain, weight loss, which leads to poor nutrition absorption and treatment delays. So in India, the prevalence is around 50 to 60%, where the majority of the cases report moderate to severe. So methotrexate, a drug which is widely used to treat, an antifungal drug which is widely used to treat various types of cancer and autoimmune diseases, is also one of the drugs to show gastrointestinal mucositis as a side effect. So currently, there are no FDA-approved drugs to mitigate the effect of methotrexate. It's due to the lack of understanding the mechanism behind methotrexate-induced intestinal mucositis. But mechanistically, chemotherapy-induced mucositis involves downregulation of PI3K AKT pro-survival pathway, leading to epithelial apoptosis. And another important contributor is peroxynitrate, a reactive nitrogen species which is already shown to overproduce in methotrexate-induced small intestinal injury. Given the fact that peroxynitrate plays a critical role, we chose epsilon, a peroxynitrate scavenger, which showed good safety in clinical trials. So, however, its protective role against methotrexate-induced intestinal mucositis in vivo is not yet studied. So, elucidating pure and driven mechanism and targeting them with agents like epsilon could address the current therapeutic gap in methotrexate-induced intestinal mucositis. This forms rationale of a study. So, we aim to investigate the protective effect of epsilon on methotrexate-induced intestinal mucositis in rats, and also to elucidate the role of AKT/GSK3 beta signaling. So at first we wanted to validate this in vitro, where we used intestinal epithelial cells which is derived from rat, where the cell viability is decreased dose dependently and the apoptosis is significantly increased in methotrexate treated groups when compared to controls. So next we checked the presence of nitrothyrosin, where like through immunofluorescence, where methotrexate group showed increased expression of nitrothyrosin, confirming the peroxynitrate production. Since nitrothyrosin is a immediate compound of peroxynitrate. So densitometry data reveal that methotrexate clearly downregulated or decreased the expression of AKT and GSK3 beta, suppressing survival. Since AKT is a pro-survival kinase, its downregulation by methotrexate clearly shifts towards apoptosis. To confirm, we checked the expression of caspase-3, a major exhibitioner of apoptosis. Subsequently, the methotrexate clearly increased the expression of caspase-3, which reveals activation of apoptosis, which is downstream of AKT inhibition. So then we moved to in vivo model, where we used rat mucositis, methotrexate induced mucositis model, where we used female visitor rats aged between 10 to 12 weeks and weighed between 160 to 180 grams, where methotrexate group received 7 mg per kg of methotrexate intraperitoneally for 3 consecutive days, and the other groups received epsilon, like 2 hours pre-treatment of 10 mg per kg of epsilon orally for the same 3 consecutive days. After overnight fasting, the animals were euthanized by CO2 and the intestines are harvested, where one part is fixed in formalin for histological studies, and the other part is fixed, other part is snap frozen for further biochemical assays. So, methotrexate showed progressive body weight loss and a reduced food intake, while epsilon plus methotrexate group showed partial recovery. And histologically, methotrexate showed villus shortening and crypt degeneration, while epsilon plus methotrexate group restored and showed improved structure and grading as well. So to assess nitrosative stress, we examined immunohistochemistry of nitrothyrosin, where methotrexate group showed strong staining against nitrothyrosin, which indicates the peroxynitrate mediated protein nitration, while epsilon plus methotrexate group reduced this staining, which confirms that epsilon as a peroxynitrate scavenger, it effectively scavenges peroxynitrate, leading to reduced nitrosative stress. Finally, again, Western blot data reveal that methotrexate significantly reduced the levels of postulated form of AKT and GSK3 beta, while epsilon plus methotrexate group partially, the epsilon pre-treatment partially restored those values near to control. So in summary, our study shows that methotrexate induced mucositis through suppressing AKT, GSK3 beta, a survival pathway through promoting apoptosis, and while epsilon as a peroxynitrate scavenger reduces oxidative damage by promoting survival pathway, leading to protection against methotrexate induced mucositis. In future, we also plan to measure pro-inflammatory cytokines, just to look in CYX, 1-beta and TNF alpha, and also to analyze AKT, GSK3 beta gene expression through RT-qPCR, and also to test the higher dose of epsilon 20 mg per kg to assess dose-dependent protection, and also identify its molecular targets to better understand the mechanism. Since epsilon is already clinically available, our long-term goal is to repurpose it as a mechanism-based therapy for chemotherapy-induced mucositis. So I would like to thank DST for financial support and Department of Anatomy for technical assistance in histology. And I would also like to thank my PI and co-PI, Dr. Pramila Abram and Dr. Muthuraman, and also my fellow researchers, Ms. Sani and Ms. Anish Dev, for their constant support. And I would finally I would like to thank the coordinators of IPSCON for giving me this wonderful opportunity. Thank you for your kind attention, and I'm happy to take any questions.
I will have a suggestion for you.
Yes, sir.
You know, when you actually have been doing the body weight and food intake,
yes, sir,
the two of the most important parameters are rectal temperature and water intake.
Okay.
And this observation could have added something to your study.
Okay.
Right?
Yes.
In future, if you intend to continue the work, so please think about it.
Definitely.
Another aspect is, now you said about the upselling.
Yes.
What is the repurposing? Almost everything coming from the CMC is repurposing on?
I don't know.
Actually, I have a question I just want to ask. What is the current clinical status of this compound?
It's
Are
in
they
stage
very
two.
much in the clinics?
No,
Are
no.
they prescribed routinely, or is they still in the stage of clinical development?
It's in phase 2 of clinical trials, but then they have tested it for.
But there are controversial reports with this compound.
Yes.
Is it clinically prescribed, or that's why repurposing? Why is it repurposing?
Yes, ma'am. Like that's why we test all of this.
Is it already in clinics?
Not like in clinics, but then it showed a very good safety in clinical trials. That's what I mentioned there. It's not like
It is approved. It is approved for some indications.
yes, ma'am. They are using it for ENT right now.
For ENT.
But not specifically. I don't know specifically.
Menias disease.
Yes, ma'am. I'm sorry.
Type 2 diabetes, but I don't taste very frequently.
Yes.
This compound is used. This is a very extended. It is a very well. How long? What is the date of approval of this compound?
I'm not sure about that. But
This is a well established, good profile, better therapy, like adverse profile, effect profile. So if the drug is very new, so you don't know about so many things about the new compound.
Yes, yes.
When they are very like dustal, parcel, then you will be able to understand what happens with the rare side effects.
Yes, ma'am. Those are the reasons why we wanted to test it out. Those are the reasons why we wanted to.
So how this your study is going to help us in medical like
clinical implications.
what is the
No, we are trying to reduce the treatment delays for chemotherapy-induced mucositis. We're just trying to reduce the burden.
You cannot generalize. This is methotrexate only. Chemotherapy is not methotrexate only.
Yeah, ma'am, but we are exploring. Like we are exploring actually. It's like it's just an ongoing study. We are yet to explore those areas as well.
Leukocyte is very common in all chemotherapy. This one takes
Not only confined to method.
Yes, sir. Yes.
Thank you very much.
Thank you.
It's a simple question that, like we said, you did the study at 7 milligram per kg.
Yes.
What is the recommended dose for the methotrexate, otherwise for the cancer patients?
It's depending upon the stage, but then right now it's
So how will you write the 7 milligram
from 5 mg to 10 mg per kg. Yeah.
7 mg regimen for choosing the drug?
It's actually in terms of rats, it's high dose. But then we want to show that epsilon can reverse the effect of methotrexate-induced mucositis, even in high dose. High dose of methotrexate.
Thank you very much. Next speaker.
Thank you, ma'am. Thank you, sir. I request the chairperson kindly felicitate our speaker, Dhyaneshwaran. I also request Dr. Rehan. Next presenter we have Ms. Zafar.
Welcome to the third speaker, Ms. Zafar from Government Medical College, Saharanpur. Title of the presentation is Comparative Study of Carbetocin versus Oxytocin in Prevention of Postpartum Hemorrhage following the Caesarean section.
Good afternoon, everyone. I'm from Government Medical College, Saharanpur, and my topic is a comparative study of carbetocin versus oxytocin in preventing post-hemorrhage following cesarean section. Introduction. Postpartum hemorrhage is a severe obstetric condition marked by excessive bleeding over 500 milliliter after vaginal delivery or 1000 milliliter after following cesarean section. Postpartum hemorrhage is a major cause of maternal death globally, characterized by excessive bleeding after childbirth. Despite medical advancements, postpartum hemorrhage remain a significant issues, especially in areas with poor healthcare access. Effective management, prompt diagnosis, and better healthcare access are essential to combat this life-threatening condition. It is estimated that postpartum hemorrhage account for approximately 25% of all maternal death worldwide. It is greatly impacts maternal health globally, accounts for one death every 4 minutes. Postpartum hemorrhage is a leading cause of maternal mortality, particularly in areas with a limited access to quality healthcare and emergency obstetric service. It is often results from uterine atony, where the uterus fails to contract after childbirth, causing severe bleeding. Other causes include retained placenta, birth canal trauma, and clotting disorder. Preventive measures such as active management of third stage of labor and administering uterotonic drugs like oxytocin are critical. Timely emergency interventions like blood transfusions, uterine massage, surgical techniques, and intrauterine balloon tamponades are vital for survival. Enhancing maternal health care, training provider, and raising awareness are crucial for reducing the global postpartum hemorrhage burdens and saving lives, especially in developing regions. Oxytocin. It is a natural occurring hormone synthesized in hypothalamus and released by the posterior pituitary gland, and it plays a major role in childbirth by inducing uterine contraction and facilitating labor progress. In obstetric practice, oxytocin is widely used as a uterotonic agent for the prevention and treatment of postpartum hemorrhage, particularly in active management of third stage of labor. During the effectiveness, it is recommended at the first time uterotonic drug in most clinical guidelines for both vaginal and cesarean deliveries. Mechanism of oxytocin. Oxytocin exerts by binding to oxytocin receptors located on the uterine smooth muscles and stimulating rhythmic contraction of the myometrium. These contractions aid in reducing postpartum blood loss by promoting placenta separation and constricting the uterine blood vessels. Routes and administration of oxytocin in pharmacokinetics. Oxytocin is administered either through intravenous or intramuscular injection. When given intravenously, it has almost immediately effect, while intramuscular administration takes approximately 2 minutes to begin its actions. However, oxytocin has a short duration of action, lasting all for about 15 to 20 minutes, and its half-life is 1 to 6 minutes, further contribute to the need of the prolonged administration of oxytocin in case of ongoing postpartum hemorrhage risk. Carbetocin. It is a synthetic analog of oxytocin first described in 1987. It designs to mimic the effect of oxytocin while offering a prolonged duration of action, making it a valuable option for the prevention and management of postpartum hemorrhage. Unlike oxytocin, which has short half-life, it has a half-life approximately 40 minutes, 4 to 10-fold time longer than oxytocin, allowing for single dose administration to maintain uterine contraction and reducing blood loss. Carbetocin mechanism of action, it's selectively bind to oxytocin receptor in the uterine muscles, inducing rhythmic contractions, increasing the frequency of existing contractions and enhancing overall uterine tone. Studies have established an optimal intervention dose 100 microgram induced uterine contraction within 2 minutes, providing rapid and sustained hemostasis. It extends duration of action, eliminating the need of repeated dosing, offering a practical advantage over oxytocin. Its methodology, aim of the study is to study the effect of carbetocin versus oxytocin in the prevention of postpartum hemorrhage following cesarean section. Primary objective is to compare the efficacy of carbetocin and oxytocin in reducing blood loss after cesarean section, and its secondary objective is to assessing the safety and adverse effects of carbetocin and oxytocin, evaluating the need of additional uterotonic, patient satisfactions, cost effectiveness, hemodynamic stability, and during use and long-term maternal outcome. My study is done in Government Medical College Saharanpur, in the Department of Gynecology with the collaboration of Department of Anesthesiology. Study design is prospective study for 18 months, and study population all pregnant women undergoing elective or emergency cesarean section for various indications. Inclusion criteria: a woman undergoing elective or emergency cesarean section for various maternal and fetal indications. Exclusion criteria: presence of hypertension, preeclampsia, liver dysfunctions, and heart disease, epilepsy, and general anesthesia, as well as history of hypersensitivity to carbetocin. Study group: carbetocin, that is women who receive carbetocin is 20 micro international unit in 1000 milliliter of solution at 150 ml per hour, and in case group carbetocin, it is 100 microgram intravenous bolus after the delivery of fetus anterior shoulder. Sample size: my sample size is of 120. Here we measured the efficacy and hemodynamic effect of two drugs: intraoperative blood loss, uterine tone, fundal height, uterine output, hemoglobin, and hemocrate placental level, and the need of additional use of uterotonic drug is assessed. It is higher in oxytocin group as compared to carbetocin group. Both groups are similar regarding to the baseline demographic and carbetocin group. Both groups are similar regarding to the baseline demographic and clinical characteristics. There is no significant difference between the two groups. But in comparison with his blood group, blood pressure, here systolic blood pressure is non-significant in both the group, in carbetocin and oxytocin group, but in carbetocin group, there is if they are not significant. They are not significant. As in oxytocin group, there is lower in blood pressure. That is, it shows hypotension. Uterine position, that is non-significant in both the group, and uterine tone, that is also non-significant in both the group. Here, in previous study, Muse et al. Comparing carbetocin, oxytocin, and misoprostol, the mean blood loss was observed to the greater in the misoprostol group compared to the carbetocin group, and the difference was statistically significant. Here, in our study, we have tried to compare the efficacy of the oxytocin and carbetocin in maintaining the hemodynamic status of the pregnant woman who has a higher risk of postpartum hemorrhage. In the present study, we found that carbetocin was comparatively more effectively in preventing postpartum hemorrhage among the study subject. During the study, the post-operative blood loss was significantly lower in carbetocin group compared to the oxytocin group. Also, there was statistically significant difference between the two groups as regarded by the occurrence of postpartum hemorrhage. The carbetocin group shows less occurrence of hemorrhage in comparison with oxytocin group. Debbie Lin et al. comparing carbetocin and oxytocin perioperatively, hemoglobin and hemocrate level in the carbetocin group were statistically higher. And in our study, the level of preoperative hemoglobin and hemocrate shows non-significant difference between the two groups, while the level of post-operative hemoglobin and hemocrate were significantly higher in carbetocin group than the oxytocin group. Carbetocin concluded that carbetocin shows the best result in controlling the blood loss and maintaining the level of hemoglobin and hemocrate values. Also, the changes in the pre and post-operative hemocrate and hemoglobins were significantly lower in carbetocin group in compared with the oxytocin. As per Etilekos et al., he selected 377 ladies who have cesarean section has been randomly assigned to receive either intravenous carbetocin 100 microgram or intravenous oxytocin 5 international units. Following the baby was delivered, the carbetocin group required fewer of eutotonic drug as compared to the constantly results. In our study, in terms of demand of extra additional eutotonic group, oxytocin needs require eutotonic drug as compared to carbetocin drug. Conclusion: carbetocin demonstrated greater efficacy in preventing postpartum hemorrhage in higher risk women undergoing cesarean section, primarily by maintaining hemodynamic effects, reducing blood loss, and requiring only a single dose of administration. These findings support the use of carbetocin as a supporting alternative to oxytocin for the prevention of postpartum hemorrhage. Moreover, its predictable pharmacokinetics and reducing side effects make it a practical choice for postpartum hemorrhage prophylaxis, particularly in higher risk cases. Thank you.
Back to your slide before the conclusion.
Before the conclusion.
Before the conclusion. Now here you are writing that is cabergoline. What is this cabergoline?
So where?
Cabergoline, pregnancy study in the last.
You are not using the cabergoline.
We have not used cabergoline.
Yes, sir.
What is that?
My mistake. So by mistake I have written that.
In fact, before a presentation, don't you practice in your own department what you in fact intend to present the conference?
No, sir.
You should actually tell this is nowhere, we are just printing it from where this word has come up.
Yes.
Another aspect is, I would like to know from you, now for the postpartum hemorrhage, the drug we use is the ergobactin, and it is said from the ergot algaloids, and it basically in the vessels they have been constricted, and that is the reason the bleeding is less, right? So loss of blood is less. If that was the thing, you wanted to compare the two things, you should compare with the ergobactin. What's this? Your drug. That means, there was something could have been done in fact. Because I get to know about this thing, that oxytocin, prostaglandin, F2 alpha, these are the drugs which are used in combination either for the induction of labor or for the abortions. And for the postpartum hemorrhage, this is repurposing of oxytocin. I doubt.
Oxytocin is a traditional, is a protocol. This is there in the liver room. You have to start with the when there is delivery baby first, so there is delivery. They given the oxytocin, but this cabertocin there. How what is the cost difference? Do you have any idea?
India is bothered about the cost.
Yes,
people can spend on the latest iPhone, but not on the medicine.
400 rupees, 5 rupees versus 400 rupees. And efficacy, how it is cost effective, you have to see. And if say just say like hemoglobin, hematocrit. So I just want to know how much information or novelty with this study of this protocol. What you want? What is your take-home message?
Yes.
This is the alternative to oxytocin. Yes. Or this will be a new thing.
Yes, ma'am, this is alternative to oxytocin, but its cost is higher than oxytocin.
Sometimes cost is okay.
Cannot be. No. And also in your slides you have used one, both the units are different. Like one time she is using the 1 unit and for the carbidazole she is using the 10 for
Is it micro?
And when you are comparing, you should show the things. That's what I think that I important for the practitioner.
सबसे important. Can you go to your first slide? Can you go to your first slide? What is the conference name you have written? I was very surprised.
Yeah, 1987.
Now International Pharmacology Conference.
Yes.
I was very surprised. What is this conference? First one. Title page.
Title slide.
कौन सा? Is this International Pharmacology Conference? Indian Pharmacology. Huh?
We have international participants.
Participants, but name of the conference I was very. Please, अच्छा, sorry, चलो ठीक है. Okay.
जब 4 बाहर से लोग आए तो इंटरनेशनल हो जाते.
I was not sorry. I
There are 25 participants. 25 participants. By the way, are you a pharmacologist or gynecologist?
Ma'am, sir, pharmacologist.
Pharmacologist.
Yes, sir.
Please, suggestion है आप थोड़ा सा इसको देखिए.
Okay, sir.
And what was your literature service source? Like that carbidazole, you said it's a synthetic molecule in 1987. So since then it's more around 25 years plus. So nobody has done a comparative study so far?
Sir, ma'am, then.
Like you should have compared the dose that are also
Yes, ma'am.
incomplete.
Yes, ma'am.
I think the last paper.
Yeah.
Youngsters are sitting around. I would like to share with you. Now, whenever we are pursuing a research, think about the project which in fact you intend to do. All pros and cons. So, if you think on all those things, probably you come out with the best of the things. Otherwise, if you intend to be the faculty in a medical college or so-called, star departments of pharmacology or others, this time the type of research is A is a lipid, one article. Second article is A lipid, second article. Third article is probably A is not a lipid, and fourth article it is not a lipid. Don't do this type of research. You have to publish the thing. In India today, either publish or perish. This concept is going on. But where in fact we are lacking the field of the research. So I think for that you have got to sit in the library a lot. Think about something, because she did not compare with the argometrin, which is the cheapest drug. In Indian psyche, Indians, they only go for the cheap drugs. That is the reason why the cheap politicians, not cheap politicians, why do the politicians say, go for the generic, branded generic and branded drugs? You understand?
Yes.
Thinking about it, let me tell you, the drug, diseases where we give the drug with a narrow therapeutic margin, we cannot afford to go for the generic drugs, only the branded drugs. So don't fall into the prey of those people, learned people. So think on your own faculties. Well, thank you very much.
Thank you, ma'am. Thank you, sir. I request the chairperson kindly felicitate Miss Lafu. Hereby, I would like to take a moment to express our gratitude toward our previous session chairperson, Dr. Lekha Saha. Ma'am, please join the dais. I request current chairperson, please felicitate Dr. Lekha Saha. I request the chair, please felicitate Dr. C.S. Gautam. I request Dr. C.S. Gautam and Dr. Nilima Dhingra, please felicitate Dr. Amita Sarwal. I request Dr. Amita Sarwal and Dr. C.S. Gautam, please felicitate Dr. Nilima Dhingra. Thank you, sir. Thank you, ma'am. Here we close the session for oral presentation. Now I invite you all for the lunch, followed by next session at 2:30 in Hall 1.